So for anyone who hasn't met me before, my name is Carolyn Downs, my title's there, and I'm chairing today's meeting. I'm one of the non-executive directors who sits on the board. Everybody's got their nameplates, but when they speak, it'd be really good just to introduce yourselves when you do speak. So welcome to everybody. Thanks for coming to this different venue today. We'll try and get through the meeting just as well and quickly as we do. We've got a moment at the comfort break at 11 o'clock. Obviously the loos are just outside anyway. There's no fire alarm, I don't think, that's been planned. So if the fire alarm goes, it's real. And I think the staff of the hotel will help us get out. We have 3 partners coming to speak to us today. From the Listening Lounge, the Jersey Hospice Care, and indeed, from my Voice Advocacy Service. So they will be coming, and they're due to be here at about 10:30. So we might have to jig, if you've got a copy of the agenda, we might jig the agenda around to fit things in, a bit quicker or a bit sooner, out of order or whatever. But we'll definitely take them at 10:30, and then, as I say, we'll break for comfort break at 11 o'clock. So without any further ado, has anybody got any declarations of interest? Oh, I'd like to welcome, actually, our new non-executive director, who should be on screen. Oh, here he is. Oh, half of him. On the screen behind. So his name is David Keane, and he's had many years in private finance, and he's our new non-executive director who's going to be covering strategic finance. David is just started, but he was already booked a holiday, so he's on holiday, and so it's really good of him to be able to join us today online, and we'll be here obviously at our future meetings in person. So, does anybody have any declarations? Oh, God, apologies, sorry, any apologies?
Obi Hassan,
Dr. Claire Gerarda.
And obviously got Mark Query, who's going to be dealing with finance. Sorry, Mark Query, who's going to be presenting the finance report today.
Yeah.
So
well, you're very welcome, Mark. So, any declarations of interest? No? We have the minutes of the previous meeting. Are people happy with those as an accurate record of the previous meeting? Very good. And we have the action tracker and the matters arising. And I think I'm right to say, Emma, that there is nothing in there that isn't already dealt with on the agenda or anything that we need to discuss this morning. No. Okay, thanks very much indeed. So on that basis, just a few comments, and the only comments from myself, as I say, I've just introduced David Keane, our new non-executive director. But today is Chris's last board meeting. So Chris has been working in Jersey now for nearly 2 years, I think, isn't it?
January I came in 23 as part of the turnaround team, but been in the interim chief officer since April of last year, so it's gone quickly.
It's gone quickly, and I'm sure it's never ever been boring either. So Chris, I think certainly from the non-executive directors here, you've been nothing but helpful, supportive, kind, and indeed extremely informative to us. So I think a really big thank you from us for your support and your time here, and the difference that you have made. So thank you very much indeed. And I know Patrick's going to say a couple of words as well.
Yes, Chris, just on behalf of the executives, also our thanks to you. You came to HCS at a tricky time, I think we could say, and undoubtedly you, I think, leave health, contribute to health at a point where it has real opportunity to spring forward, and a lot of that's down to your leadership. We're all very grateful individually for your unwavering support, your good humour, even at the most trying of times, and we wish you a very speedy recovery, and we're pleased, even though it won't be for very long, you'll be back in an advisory capacity, and I have no doubt we will be knocking on your door for your sage advice and wisdom and help and support even when you're back, and we look forward to that.
Thank you, Patrick.
And just to say to people, Chris is not desperately ill, he's having routine surgery. So, on that note, we will move on, and it's over to you, Chris, and it's your report. Thank you. Oh, Tony, sorry.
Yes, I can't get this to work.
Press the button.
Press the red button.
Is it the button at the bottom?
Yeah.
Red button on the side.
The side, there's a red button on the side. Like your TV control on and off.
Oh, hello? Hello?
That's it.
Regrets. I wanted to ask the medical leadership and the Cohen Brown leadership training more generally that you referred to in your last report. It looked like a really, really good initiative. Wondered how that was going and how many more people were enlisted.
Yes, it is a good initiative. A number of others have attended since I attended, and Cheryl, I think we've always had good representation in health across the different tiers. So I think now they've finished that programme has finished, or this cohort of training is finished, and HCS has been well represented at all those programmes, along with other government departments. But Cheryl, do you want to give your feedback?
I can add to that. So we've had a cohort of 48.
You just need to work the mic.
We've had a cohort of 48 senior leaders who have attended that training. We have all the executive team who've attended, and obviously the majority of our senior leadership team have attended, and the feedback has been very good. The request has that we have an opportunity to continue that programme, but that's obviously something that is being developed with Government of Jersey.
Thank you, very encouraging. Thank you.
So, Chris, your report.
Yes, thank you. Can everyone hear me? Sorry, I've got I'm just recovering from a bug, and I've got blocked ears, so you might be able to hear me, but I'm not quite sure I can hear myself, but I shall keep going. First of all, thank you, Carolyn, for those kind words, and Patrick, I wasn't expecting that, because what I was expecting is actually to give an announcement about Patrick Armstrong, our medical director, because a message is going out to all HCS staff today, and I just want to read you what that message says. Mr. Patrick Armstrong, MBE, has decided after 5 years in the role to stand down as our medical director as of the 1st of January 2025 to focus on full-time clinical duties. Patrick's an orthopaedic surgeon, as many of you will know. We will therefore start the process for recruiting a replacement with the Jersey Appointments Commission. I would like to thank Patrick on behalf of the board for his dedication, commitment to patient safety, high standards of clinical governance, and his integrity in addressing often very difficult and controversial issues during his appointment. We should also recognise his strong leadership during the pandemic, of which he was recognised through the award of the NBE. I and all the board wish you every success, Patrick, in your transition back to full-time clinical practice, so there will be more patients that can benefit from your orthopaedic surgery. So that message, or a version of it, has gone out to all staff today across HCS. So before I go into my report, that's what I wanted to say. So, as always, my report sort of summarises some of the key issues, many of which you will see as substantive items in the board report. But I just want to highlight a few things, because today is the first opportunity that the board has to consider both the Getting It Right First Time, the GIRFT report, and the Pharmacy Review report and action plans. The advisory board will be cited on progress through the Quality Safety Improvement Committee, which is chaired by Dame Claire Gerarda, but we have those on the agenda today. Just some points on cultural change. I mentioned in my report about the nomination platform for the Government of Jersey Public Service Awards. This was launched back in July, and it's an indicator when you look at things like this of employee engagement, about how many staff wish to engage with such initiatives. And I'm pleased to say that the last figures, Cheryl, that I've got is 426 nominations have been put forward by HCS, which compares to only 183 last year. And I say this is one indicator, only one, but one indicator that we're seeing greater staff engagement. I think when it was 183, it was 42% higher. I haven't worked out the percentage yet. 426. The other interesting part that we're looking at those nominations is around the medical engagement metric, which shows that medics are being nominated more than any other professional staff group, and that's certainly not been the case in the past, where medical engagement in these sorts of things was very, very low. The Government of Jersey Be Heard survey was launched on the 9th of September and was running for 3 weeks. I think it closes on the 27th of this month. This again is a survey which we consider as incredibly important because it enables us to focus on where improvements need to be targeted across HCS. And we know, as I said, when I first arrived as part of the turnaround team, and I've said it consistently ever since, that cultural change is a long haul, it's a marathon, not a sprint. So we need to look at these results over the period of the next 5 years. We continue with our targeted programs of organisational development interventions, where we have departments with specific cultural challenges, and that continues and has been led by Cheryl Power. You'll also see in my report a number of achievements were recognised with in HCS, including very great staff improvements. I won't go through them all, but I do just want to highlight a couple here. That the HCS Learning Disability Service, Andy, held a number of community engagement events and pop-ups, which I believe were incredibly successful, so thank you, Andy, for that. We also importantly welcomed our new lead for advanced practice, independent prescribing and practice development, again a significant post improvement. A new cohort of foundation year 1 doctors started in HCS, Patrick, and we welcomed them on board very recently. And another important thing I just want to highlight is the launch of the Neuro-Inclusive Jersey 3-year strategy and survey to capture island feedback. That's an enormously important survey, so we're looking forward to the results. Quality and safety, you'll see there I talk about where we are with PALS. PALS are now in easily identifiable uniforms, providing a more approachable and visible presence, we believe, for patients. We've been undertaking an awareness campaign incorporating social media, information leaflets, etc. And we've seen, which is good news, a result of about a 300% increase in PALS contacts, which is good news. And this reflects, I think, the success of the team, Jessie, and in promoting the accessibility and support that we can give to patients. You will see there's a chart in my report that shows both complaints and compliments, and it's pleasing to see, of course, that there's a significant number of compliments compared to complaints. But those complaints are reducing, which is good news, but we continue to ensure that we learn from everything that we receive in the way of complaints and feedback. I think it's good to see, of course, that we've seen a marked increase in compliments for our maternity services, which I think is a positive reflection on the hard work that's now gone into implementing the maternity improvement plan over the last 12 months. So well done to everyone in maternity services. This month sees the ongoing commitment of growing local talent as the Faculty of Health Education. We welcomed 14 student nurses, 3 student midwives and 1 student operating practitioner to Health and Community Services. I was able to meet with the students the other day and wish them every success as they embark on their exciting career. Infection prevention and control, clearly important. We've had a very busy summer, but despite this, the numbers and high numbers of admissions, we're continuing to deliver good care evidenced by the healthcare associated infection rates. They're listed in my report. Just to also highlight, we have seen physical environmental improvements in a number of areas that obviously contribute to improved infection control, health and safety, and standards and compliance achievements. We've seen Plymouth, Beaumont wards, and now currently Bartlett restored and refurbished, and bringing in line some additional bed capacity now for the winter, which is going to be important. And as we go through the quality and safety, or the quality reports, you'll see why that's the case. Finance, Mark will cover in his report, although I do just want to highlight something around the forecast and the FRP delivery. The board will see that we are due to actually exceed our financial recovery plan target savings. However, the additional cost pressures that we're seeing has made it necessary to look for about another £5 million worth of savings. Now, we have found a number of additional savings. Not all of them we feel are absolutely embedded as regards to delivery. We still have about £1.6 million worth of savings to achieve to deliver the 24 million deficit that we need to achieve. If we don't achieve those additional savings, you'll see in my report and indeed in the finance report that we'll be getting close to, well, 29.5, close to 30 million deficit. So it's absolutely critical that we implement the level of savings to bring us back down to £24 million. So active work taking place on doing that. We've got 3 months in effect to ensure that that is delivered. Workforce, again, Ian will cover that. I would like to thank Ian's team. I know it says, and I mentioned in my report, it is under significant pressure, a lot of activity being covered, but Ian will deal with that in the finance, in the workforce report. One thing I just want to mention, I have agreed that the Director of Cultural, Cheryl, and Engagement and Wellbeing will work very closely with the Director of Workforce from this month to develop our people strategy for HCS, which is going to be a critical component of the future. We do have a combined workforce tactical plan, as I would call it, for HCS, particularly around recruitment. However, these plans are only part of the development, or can only be part of the development of a much wider workforce strategy that we need to develop for HCS over the coming months. You'll see in the report I've listed some improvements around waiting lists through our waiting list initiative programme. In particular, we have seen and treated now almost 200 patients with a partner ophthalmic provider in the UK. We're anticipating that by the end of March 500 patients will have benefited from this initiative. We've seen over 1,000 patients who have received echo diagnostic tests since the end of May as part of the increased diagnostic capacity initiative. We've also, very importantly, and this is something actually that was recommended by the Hugo Maskey-Taylor report, that the cancer team now have implemented in Jersey a UK-wide Somerset Cancer Registry, which you will see from my report how important that is, and in collaboration with Improving Cancer Journeys Jersey, we're now able to provide a much more holistic needs assessment to support ongoing cancer treatment. We're currently in discussions with an external provider to support us and increase our capacity in dermatology, where we know we've got unacceptably long waits, and we've also found some additional resource to support our clinical genetic service, which again is under considerable pressure as regards to long waits. Very pleased to say that we've now appointed a new gastroenterologist, and that will increase our capacity in that area for endoscopy, diagnostic testing. A new stroke consultant has now commenced with us and has been focusing on TIA service to see and treat patients much more quickly. The wait before was unacceptable. And finally, we're pleased to say that we have appointed a second dermatologist. This is a vacant post that's been hard to recruit to for, it feels like, many years, from London, who will commence with us in October. You'll see in my report certain changes that we've made, or I've made, to the clinical care group structure. Article 36 suite, I believe, received some media interest. This is a new facility for islanders who are detained by the police due to mental health concerns, opened at Clinic Penel on the 9th of September. That is a big step in the right direction. You'll also see I've covered in my report about the new hospital facilities. Good progress has been made, and I think many of you will be aware that the planning application for the acute hospital at Overdale has been submitted to the Government of Jersey planning portal at the start of September. The next steps for planning application require the Minister of the Environment to review the information and determine the planning application process. So we look forward to seeing that move forward. Commissioning Academy event, I've included some information there about the cross-government Commissioning Academy programme, which HCS involved itself in. There was a well-attended workshop, perhaps approximately 70 attendees, close to 40% were non-government organisations and charities, so that's good news. And last but not least, those small things that make a big difference: carbon literacy training. An endoscopy technician in HCS introduced an initiative to firstly reduce the number of plastic jugs we use in the hospital, and secondly sought new ways to source sterile water washrooms, as well as a considerable reduction in our carbon footprint. That also saved us just over £9,000 a year. So these initiatives from individual and committed colleagues are contributing to the bigger programme. So any questions on my report, I'm very happy to answer.
Thank you, Chris. Tony?
Hi, yeah, thank you. I should have said, my name's Tony Hunter. I'm one of the non-executive directors with a social care, social services background. I wanted to, Chris made reference to learning disability services, so I just wanted to jump on that bandwagon really and say that I had a fantastic morning yesterday with staff and service users in learning disability services, visiting Pineridge, Mason, Jubilee, Klondike and Moran. I've got pronunciation on there, but it's where the 10 flats are. I was very, very impressed indeed. I've worked in a number of council, local authorities, NHS environments in the UK, and this stands alongside the best, no question really. Not only in the quality of the facilities, but more important than that, the highly personalised nature of the support provided by fantastic staff. You know, all of the facilities in the world can never take the place of really personalised care, which really is about the individual understanding his or her wants and needs and so on. It was a fantastic morning, and I'll be expressing those thanks to the staff involved. Thank you.
Yeah, I just done that on myself, and Julie did the same visit round in June, I think it was, and likewise, having worked in local authorities in the UK, I thought it was alongside the best without a doubt, and like you say, the extraordinarily high levels of care that the staff had, and love really for the people that they care for, I thought was really outstanding, and very personalised services as well, so definitely an absolute star in the crown here. Just coming on to something a little bit more difficult, however, Chris, it would be useful because we've heard a lot about rheumatology, and it would be really useful for you just to update us where we are with referrals to the Viscount. I don't know whether that's yourself or Patrick actually.
Thank you, Chair. Where we've got to, we are still going through the 2019 up to the current dates cohort of patients who have died from any reason at all. There are now 217 people in that group, and that's simply because people come to the end of their natural life, and if they have been under the care of rheumatology, we will review them. Out of those 217 cases, there's still 67 to review. Of the 150 who have been reviewed, 34 have now been referred to the Viscount. So that's where we are. We hope to have finished looking at patients in this cohort by the end of December. The team spoke to the team yesterday. A little bit cautious about that, but if it's not the end of this year, early next year, and then they'll be able to start looking at deaths from previous years prior to 2018. But 34 patients have now been referred to Viscount.
Thank you.
It's just worth reminding ourselves that the Viscount did ask us to extend, didn't they, Patrick, from looking from back to 2019, but has expressed concern that we really should look back further than that on those patients that died under the care of the rheumatologists. So that's why we're going back further.
So, do we have any idea of the timescales to which the Viscount will be working? Because this could just go on and on and on for years, which and I think at some point we just need to come to some conclusions.
I think you're right, it will go on for a long time. It's quite a slow process going through each death, so there's a process of anyone who's died who has been under the care of the rheumatology clinic at any point, that care will be reviewed. If there's concerns about that, then we will do a mortality learning review, and if there are concerns from that, then that case gets looked at individually. Now, I think that is why we've made some adjustments to the medical leadership team, so Dr. Adrian Noon is now concentrating on that work, because it is time consuming. And I think unfortunately it will go on for years. Some of it will be determined by what the Viscount, what actions he wishes to take, and in collaboration with the police, what actions that they wish to take. So some of it is now out with of HCS really, and but we'll just have to be informed by them. But I think unfortunately this will probably go on for a very long time. I think we have over duty to anybody who may have been under the care and who may have concerns to make sure that we can answer their questions.
Thank you. And I just want to say on infection control and the stats that you include in the report here, in which we have actually in performance reports as well, and the fact that we've had no cases of MRSA, C. difficile, and methicillin, which is amazing actually. And I just, infection control rates are deteriorating significantly in the UK, and that is not the case here at all. And so I think that's something to really, really definitely applaud all our staff, the nursing staff and the clinicians who are ensuring that remains the case. And there are numerous cases of E. coli as well in the UK at the moment in hospitals. So I think it's really, really to be lauded that the fact that the infections are not happening here in the same way. So I think a big well done to everybody in that. I think all the other, in case everybody thinks that this is just a report where we say well done, all the other issues that are slightly less well done, if I might put it that way, are on the agenda. So we'll cover them there if that is okay with everybody. So Chris, thank you very much, and once again, thanks very much for all your support and your extremely hard work whilst you've been here as well. And I'll just say as well, Patrick, because thank you very much to yourself as well, and good luck going back to a normal life. Lucky you. Yes. So, right, okay, so we'll move on now on our agenda, and we come now to the finance report, which is definitely one of the less positive reports on the agenda. So, welcome to Mark, who is here on behalf of Obi. So, welcome, Mark.
Thank you. Good morning, everyone. Sorry, my name is Mark Herray. I'm the Deputy Head of Finance Business Partnering, supporting HCS. I'm here on behalf of Obi Hassan, the Finance Change Lead. I'll take the finance report as read and just go through some key highlights of the finance report for August 2024. The financial position to the end of August is showing an £18.9 million overspend against the year-to-date budget, which equates to a monthly overspend average across the year of 2.4 million. As Chris referred to, the current forecast is for an overspend of 24 million, which is the figure that has been discussed with the Treasurer and the Chief Executive of the government, and has been indicated it would not be accepted for the health overspend to exceed that. However, over the summer period, the underlying forecast position that I and my team have prepared was indicating a deficit of up to 29.5 million. So therefore, it was in July, an executive financial recovery group was formed, known as COBRA within the department, to identify further mitigation actions that could deliver in the region of 5.5 million before the end of the year. The reason for the deterioration in the forecast from 24 million to 29.5 came from a number of worsening cost pressures within the department, we saw a downturn in the forecast around the expected income being received through the long-term care benefit scheme, partly due to closure at beds due to operational reasons in the Sandy Brook nursing home, and partly due to correction of a historic overbilling issue of long-term care benefit, where health were billing for clients for which long-term care benefit was not forthcoming from the fund. Increased costs of social care packages and mental health placements, a reduction in the expected delivery of surgical income and associated private patient accommodation income, resulting from increased public activity and from the movement from procedures being conducted in theatres to day cases in the day surgery units. Seen further overspends in consumables costs, particularly in theatres, in surgical services, but also in medical services. Overperformance on acute care contracts in the UK, including our largest contract at Southampton, which had significant overperformance from February to June, and inflationary impacts on the cardiology contract at Oxford, where tariffs were increased from April, as well as high cost drug pressures, particularly in medical services. So that was the reason for the move from 2024 to 29.5. As I say, the Cobra Group has been formed, has 5.5 million of schemes to identify. At this point, as Chris indicated, there is about a 1.6 million gap in that plan, and we have 3 months to try and close that gap. In more positive news, against the financial recovery plan savings target for the year, which was set at 5.2 million, that has already been exceeded to month 8 at 5.4 million, which is made up of 3.6 million achieved against the originally scoped schemes and 1.8 million of mitigation schemes, which includes things like savings from vacancies within the department. The forecast full year savings against the FRP plan is 7.1 million against the plan of 5.2, an over delivery of 1.9 million. But with the additional operational cost pressures arising, that those additional savings that the Cobra Group were looking at need to be delivered. So there's a note of recovery actions to be taken. So we've got the Cobra Group meeting to identify the gap between 29.5 and 24 million. Ongoing support and challenge meetings with care groups to identify opportunities for mitigating the financial position. Executives looking at service change options, list of options shared with the board and the Minister for consideration to eliminate the forecast deficit. If these are approved, they'll require quality impact assessments and a restructuring provision to be made available for implementation, and discussions with Treasury and ongoing around sustainable long-term funding. There has been work ongoing for the last few years around what the future of funding the health service in Jersey will look like, and on the back of those reports there are discussions ongoing with policy colleagues, the Minister and the scrutiny panel as well. It was discussed that last week. Okay, thank you. I'd like to invite any questions.
Julie, you chaired our finance committee yesterday. Is there anything you particularly would like to raise from that?
Not particularly. I think we've had a good run through the situation that we're in. I don't think anybody can deny that it's not pretty dire and challenging. And I think we're going to be working incredibly hard, and certainly the executives will right up to the end of the year trying to squeeze every single bit of saving out that we can. It's just indicative of the pressure, I think, on all health systems currently, with the growth in demand and trying to get into preventative investments.
Preventative investments as well as the ongoing operational investments is a big challenge. So yes, I think, thank you for the explanation. I think it's very detailed, which is good. I understand it, but I am a little bit concerned, as I think we all were yesterday, as to whether or not we can actually get there. Yeah. But we have to, because we simply can't overspend by the end of the year.
Yeah, okay, thanks very much. And I can't see if David is indicating, but David being our strategic finance lead, I wondered if David had any comments that he would like to make.
Yes, thank you. No, I agree with what Julie said, and I think it's very good that there's a detailed level of transparency around these numbers, but clearly it's a worry that with only some 2 or 3 months to go to the end of the year, it's going to be very difficult to close that gap. And I guess I raised some concern yesterday about actually what this means for 2025, where I understand the FRP savings are scheduled something like double, 10 quid something, I think. So I think we need to think about 2025 as soon as possible, really, to make sure that we don't start the year off already knowing that we're going to be in deficit.
Yeah, David, that's absolutely correct. The budget setting process, in fact, started this week, I think, Mark, around 2025, and one of the key figures really will be our exit run rate into 25 from 24 is going to be key. So it doesn't leave us long to get that down. And with all things, saving money is easy as long as you don't care about the consequences, but of course we have to care about the consequences, and any major changes that we now need to make and will have an impact, I believe, on the level of service, not on the quality, but on the level of service that can be provided. That would be inevitable. But nevertheless, we have made some great progress with as Mark said, with the financial recovery plan savings. We're exceeding what we said we'd deliver. There is a very positive move in the reduction of agency costs in nursing, particularly, Jesse, where recruitment has been very positive. I don't want to spoil Ian's thunder, but a couple of weeks ago we had about 50 nurses in the pipeline new nurses waiting to start. So we've seen significant reductions in high-cost nurse agency. Not the same necessarily in medical staff, but in nursing we have benefited from that, which has contributed greatly to the financial recovery plan. But next year's planning is important, but we do have to ensure that we deliver the 24 million deficit position this year, which may require some tougher decisions in the next week or so.
Yeah, thanks. So I don't think any of us underestimate the challenge ahead, and it is October virtually. So that's 3 months in which to make those final savings. So as Chris says, there's going to have to be some tough decisions made, and we can't, it's got to be immediate, and therefore that will meet service levels. There's no question of that, as you've just said. So we just need to be aware of that. Anyway, so I think we'll leave it there because we have a discussion ourselves later as a Part B item on what we might have to do to address that. But I would like to say, well done, Jesse, and the nursing staff for what you've done in terms of reducing agency costs. It's pretty brilliant, and your recruitment campaign has been successful. That shows that it can be done with the right effort and focus. It can be done. But I think one of the things that we just need to remember is the majority of the pressures are non-pay. They are social care contract costs, they are medicine costs, and they are contracts that we have to purchase outside Jersey, and our ability to control those is limited and longer term in terms of how we procure, whether we have strategic relationships with other hospitals, etc., whether that be in the UK or France or wherever. Those are longer terms. We've got 3 months in which to make these savings, so that's pretty important that we do that, because there is, as I say at every meeting, the fiduciary responsibility to do that. So we'll move on from that, but it is challenging, I think, and I think it's worth saying it's not just challenging in Jersey, it's challenging in the UK as well. All the 3 hospitals I'm involved with in the UK are all overspending, every single one of them, for exactly the same reasons that we are here. Those contract costs are just increasing constantly. Getting people out into social care is really difficult. All of those same issues. So Jersey's not alone in that. Okay, so on that basis, now we are definitely ahead of time, so I'm going to skip on the agenda because we've got colleague partners coming in for 10:30. So we will go on now to agenda item 9, which is the Quality and Performance Report. 8. So that's over to Executive Directors. You usually start off on that, Claire, don't you? Do you want this?
Please,
Yeah.
Thank you. Good morning, everyone. Claire Thompson, Chief Operating Officer for Acute Services. I'll take the paper as read, but just to pull out some of the key positive and challenged areas in regards to operational performance over acute services. Colleagues will note that we've had an increase in patients waiting over 52 weeks for appointments. I can confirm that they are patients who are waiting for routine appointments. The actual overall size of the waiting list for outpatient referrals is very steady actually, but obviously we've had some key challenges in a few specialties, some of those that Chris has already alluded to, but colleagues will be aware of the recovery plan that we've got in ophthalmology, and I'm confident that that will support a return to the reduction and the trend that we've seen over this year, which will be positive. Also, the new colleague started in gastroenterology will bring additional capacity to the end of the year that we haven't had the benefit of in previous quarters this year. Also, we've got some new software that we implemented that will support our clinical genetics pathway. So particularly those three specialties that are making up those core and the challenging in the patients who are waiting the longest will pick up their recovery as we move towards the end of this calendar year. We do have some positive news in relation to dermatology, but that does remain, I suppose, our highest specialty in terms of risk. The recruitment, which is really positive, but I think obviously we do see, and as Carolyn has alluded to, we know that that's a very challenged specialty to recruit to in the UK and other countries. So I suppose that's the highest specialty of risk. However, the board, I'm aware, had a paper while I was absent in the summer, and telling us, describing the aspirations for service development, and we do have a insourcing opportunity that we are progressing with support from commercial services, which I'm confident will bring some relief to the challenge in that specialty. In terms of being confident that our patients are safe, we obviously do use our clinical capacity to review and make sure people are not coming to harm. So we have a weekly PTL process where we can see that patients who are the most urgent referral categories and who could be linked for a cancer are prioritised, and we're very happy with our performance in that department. But obviously there's always the balance of using the clinical capacity we have to see patients rather than conducting harm reviews, but I'm confident that we've got a strong process there. In relation to people waiting for treatment, obviously the more people we see in outpatients does bring pressure, but the board will know that we were bringing patients, the number of patients waiting the longest for elective care. Again, we prioritise every day those patients waiting for urgent surgery, but unfortunately it's the routine patients that then can wait longer. However, we were reducing that over Q2 and Q3, as the board will note, and the slight pressure over the last couple of months has been because we've lost theatre capacity due to really important planned ventilation works that happen on an annual basis. So now that's completed, we'll see that pick up its recovery. The access to diagnostics, that's a developing metric. Again, we've advised the board that this was a new performance monitoring tool that we wanted to use. The variance is due to additional data, so we're now monitoring our performance against more different types of first diagnostic tests. This is a metric that's used very broadly in the UK and is key 15 diagnostics. So I'm happy to maybe update the board in more depth at that point, but that's the swing is absolutely in line with our data development tool that we needed to develop the systems to get that data. New to follow up, I'm confident we monitor that at specialty ratio. We are looking to see what initiatives such as patient initiative follow-up could be used as we go into next year, because that will bring capacity. The DNA rate, we have seen some pressure over the summer. Unfortunately, that seems to be a consistent picture every summer. If you look back through the last few years, we always see an upturn in July and August when, unfortunately, individuals may not be available to attend their appointments because they are off island. But the changes that we're going to make as we go at the end of this year and into 25, where we're going to ring people to book their appointment rather than receiving a letter, will obviously give us and patients confident that the appointment that we're allocating to them suits them, their lives, and are more likely to attend. So we're not losing that vital capacity. elective theatre utilisation, we are slowly improving. We have had some pressure in terms of on-the-day cancellations due to some equipment issues with one particular specialty, but we are loaning in equipment to get that resolved. Emergency care, we are seeing pressures in terms of our 12-hour performance. We know that's about availability of beds. And I know Andy's going to talk about particularly the work that he's leading in relation to delayed transfers of care. However, obviously it's incumbent on those in acute services to know that we're using our capacity in the best way, and we can see in particular wards such as AAU, Corbière, we have got some significant reductions in length of stay, which is fantastic. So a further assurance that we're using our beds in the best possible way, and people getting really efficient, swift care. Our performance broadly in terms of the 4-hour target, again, benchmarks well with the UK, but of course that's something that we want to plan really well for, how we know we will get further upswing in demand as we go into winter, and we've certainly had some busy days this month so far. So I think those are the major highlights and points of issue to bring to the board. Thank you.
Thanks, Claire. Do we have any immediate questions on the report?
I just wouldn't mind one. You briefly mentioned patient-initiated follow-up, which has worked incredibly well from my experience in the UK. Is that something that, Claire, you think we can get into place in the first quarter of 25? Because I think it will be of great help as regards to managing capacity.
I do. So we're working with colleagues in digital services. Thank you. Working with colleagues in digital services so we can bring that online. So Emily Hoban, Head of Access, is leading discussions, and yeah, that's absolutely something that we want to do.
Thanks, Claire. So having heard how successful we've been in the recruitment of nurses, we've got a 4-month delay in the starting of the doctor for ophthalmology, and I wondered what had caused that 4-month delay, given ophthalmology is one of our worst waiting lists.
Just individual circumstances. So
Is it? Okay.
Yeah, yes, yes. So yeah, just individual circumstances.
Okay. That's.
But we have had locum staff here in the interim,
Oh,
obviously.
okay.
Yes.
Okay.
Yeah.
Okay. Okay, so we expect that one then to move considerably once that person starts in January, or if we've had locums, it's not going to change, I don't know.
Yes, so we've now got that additional capacity with the locum, and then also in relation to our cataract, particularly recovery programme, then that will continue to support that specialty.
Okay, and one of the other questions I've got, Claire, I know I asked this a lot, is the whole issue of people on waiting lists for a long period of time, and whether we can absolutely categorically say that no one is experiencing harm from being longer on the waiting list, and you always say yes, you do that. I think what might be useful at a future meeting, because we get the same reports coming forward on performance, I think it might be useful for us to understand exactly how you do that harm analysis, who's involved in it, for which different, I can't think what the specialisms,
yes,
etc.,
yes, yeah.
and how you do it, and how you then advance people. And I would also be very interested to know that mix between private and public patients in that as well. So I just think it would be really good for us to perhaps have a deep dive into that, which comes here to a future meeting, so that we can really, really say, yes, we've not just had an assurance, I completely believe you, but we've not just had assurance like that, but we've actually gone through what the process in the system is for determining whether there is harm.
Yeah.
And it might be that happens better in some specialisms rather than others, I don't know.
Yes.
But it would be good if you could bring that forward for a future meeting.
Absolutely, yeah.
Okay.
Happy to do that.
All right, and thank you very much.
I think, Claire, you mentioned about delayed transfers of care and medically fit for discharge, and Andy, I think you're going to cover that.
Yes, thank you.
That one's better than this.
Thank you. Thank you. So I'm Andy Weir, I'm the Director of Mental Health, Social Care and Community Services. So the DTOP position, we last reported in detail to the board in March, and at that point we were running an average of 28 people delayed it's important to remember that last summer we were running an average of 40 to 50 people delayed. So we've seen a deteriorating position since March, although not thankfully to the extent that we were in last summer. So the current position is that there were 31 people delayed in the hospital. So that's 21% of our available capacity. There are 150 operational beds at the moment. The trend is significant and the reasons are significant. The vast majority of those people are waiting for nursing home beds or specialist dementia provision. So today there are 16 people who are waiting for a nursing home bed who don't need to be in hospital but can't access a nursing home bed. And there are a further 6 people who are waiting for specialist dementia care in the community. There are actually only 3 people who are waiting for a package of care in the community. The discharge team have significantly accelerated access to packages of care, and we've seen an ever-reducing number of people that are waiting for home care. That's been particularly, as I spoke about previously, helped by the brokerage system that we've introduced with CLS. But the idea that people are waiting in the hospital for home packages of care is just not true at any volume. The significant issue is nursing care and dementia care. And beyond that, there are a couple of people that were waiting for home adaptations and in order to go home. There are a couple of people that are waiting for residential care, and we still have 1 or 2 people at any given time who wait through choice, essentially, because they won't leave until the placement that they're waiting for becomes available. They don't accept alternatives. So that's a low number, but clearly adds to the overall position. We've had some nursing home beds closed at Sandybrook since October following a flood and that required refurbishment, but I'm pleased to say those beds are reopening in the next 2 weeks, so we will see a slight increase in our own nursing home capacity. But across the island, we are seeing an increased reported reduction in nursing home capacity due to temporary closures particularly. So that's one of the things that's contributing to this significant issue for us. Unsurprisingly, there's a significant amount of work going on. We have a final draft discharge policy which seeks to address this issue of choice and of people choosing not to leave the hospital. The work with CLS around looking at the whole system and looking at how we commission and how we pay for particular community activity is currently near to fruition. And as you saw in the finance report, the work that we've been doing to accelerate community care has actually resulted in a significant overspend. So we're spending £3 million more than we have a budget for on social care placements and packages currently. But if we didn't do that, people would just sit in the hospital for longer. So that's the particular cause of that overspend. The thing that we haven't cracked as yet is creating additional specialist dementia care. This is particularly dementia care for people who have dementia but also who have complex needs. They're the people that are waiting the longest still. We have some work going on at the moment at Rosewood House on the St Saviour Hospital site, which will give us some additional bed capacity, but that work won't be completed until March. So there's no quick fix there. So clearly one of the things that my team are doing is thinking about how quickly can we find alternative provision. But there's no quick answer to this.
Tony.
Thank you for that, Andy. You made reference to the importance of well-delivered discharge policy and procedures, really. And I was wondering if you had any comments about the capacity of the social work discharge team.
Certainly. So we planned to increase the capacity of the discharge team by 1 social worker and 1 assistant social worker. We've done that. I chair a meeting every week where we look at every patient that is either fit to leave hospital or nearly fit to leave hospital, and we go through what's the plan, what's the current position, and who's doing what. I can't say enough that the social work discharge team, which is also supported by a senior nurse, work incredibly hard and are absolutely on top of what they're looking for and how long they're waiting and what the issues are. So the discharge team is identifying very well for us what the issues are. It's the capacity issue that's creating the problem for us.
Thank you.
I think one of the issues is, and it's in the longer term, is there are going to be, sadly, more people with dementia over the years as populations become older, which is obviously a positive thing. But and hopefully, care for dementia and also cures for dementia, they are progressing. But the only way we're going to be able to really deal with this is to create a market, because the private sector
or the community sector either can't afford or are not willing to create that market themselves. At which point I think government has always got to intervene, and if there is no market being created, the government needs to intervene to create a market. And I think we're going to have to do that, because otherwise every year we're going to talk about the fact that there's increased costs, that we can't cope, that we're overspending, we've got to cut back on maybe elective activities, whatever, to cope with these overspend. And the only way to do it is to actually intervene in the market and create spaces ourselves. So I think that that's definitely one of the longer term objectives when we've got the new overarching integrated health and care system for the island. I personally think that should be one of the priorities, is where does the market need interventions and how is government going to do that? I think that would be a really positive first thing for that new system to start thinking about.
So in good news, these are specific actions within the dementia strategy that we published earlier this year. So there's a specific action which is about redesigning the dementia care pathway, and that includes how we better support some people to stay at home longer, I think. But then there are very specific actions around looking at longer term dementia bed capacity and how we manage that. I think we do that in two ways. I think we support mainstream nursing homes where they can to manage people for longer, because that's one of the challenges that we have. But I absolutely agree with you. I think we're now at the point where we're talking about we need to think about state provision for people with the most complex needs, because there's no other evident way forward.
And what I would say from the conversation we had earlier about the state provision that there is for people with learning disabilities, we're actually good at it. So, I mean, I don't think we should be frightened or worried about it. We're good at it and successful at it. So, I think we should really need to push in that direction. Yeah, good, great. Chris, and then we'll move on to our partners.
Yes, partners are very important in helping us resolve this issue. Just to say, market intervention is critical from my point of view. But I think when we often talk about delayed transfers of care or medically fit for discharge, I've attended a number of ward long length of stay meetings with the clinicians and the teams, and these are people that sadly are sat in acute hospital beds that don't want to be there, shouldn't be there, and the longer they stay can have a negative impact on their outcomes. So this isn't just numbers of beds, this is people that I meet on the wards that really desperately want to be somewhere else. So it is something that has to be resolved as quickly as we can make it happen.
Mm-hmm. Thanks. And just finally, just back to Andy on mental health waiting lists.
Thank you. So in terms of the mental health performance, the mental health services are still doing really well around access. So we're still seeing 91% of people in crisis within 4 hours face to face, and we're seeing 87% of all referrals within 10 working days, which is superb. So they're sustaining their position really well. And I'm also pleased to see that we're sustaining following people up on discharge from hospital within 3 working days. That's an important safety KPI in mental health services. We have still the issue in Jersey talking therapies. We're seeing an ever-increasing demand. We received 150 new referrals this month. We're seeing people very quickly, so 97% of people being assessed well within the 90-day KPI, but we still have a lag on treatment, so 42% of people are waiting over our 18-week standard for treatment. This is an improving position, and we are recruiting, so I'm hoping that that position will be sustained and will eventually reach the target, I hope, and with associated reduced waiting time. The page 21 I'd referred to you to of the QPR, that shows our greatest achievement and our most difficult struggle really. I can't congratulate the Dementia Assessment Service enough for the work that they've done in recent months to reduce the waiting list for a dementia memory assessment. We were really concerned about this towards the end of last year. They are now almost within our target and are down to 53 days. The graph shows the significant improvement they've made in a short space of time, and this is about the team working differently with a little additional capacity, but actually they've reorganised themselves to achieve this and to make sure that this is sustainable. So I think that's a really good piece of news. Our biggest challenge still in terms of waiting lists is the ADHD assessment waiting list, which is ever rising, and there's a separate paper later on the board in relation to that. The other thing that we're slightly concerned about at the moment, which isn't recorded in our KPIs, is in relation to access to specialist tertiary psychological therapies. The waiting list for that is growing. That's predominantly due to vacancy. Half of the posts are empty, although we are recruiting. We're actually interviewing shortly. So I'm hoping that we again will be able to change that and turn that around. But certainly we need to keep a close eye on that, I think. And then there's nothing remarkable in terms of the social care KPIs. The Learning Disability Service has done well to recover their position around people with an annualised health check, and the social work team continue to exceed the performance target in relation to assessments being signed off in a timely manner.
Great, thank you very much, Kathy.
Thank you, Chair. Thank you, Chairman. I'm mindful of time. It's Cathy Stone, Chief Nurse, Chief Midwife of the Change Team. I'm just minded to bring the board to the attention of the maternity performance indicator dashboard. I think our Chief Officer opened up by acknowledging the compliments to the service, but compliments need to be triangulated with quality of care. And if we look at our maternity performance indicator dashboard, when we're looking at access to service, timely interventions and the outcome for both mothers and children, this is a very different picture than what we were looking at a year ago. So please, I would really commend our staff for the work, but actually that improvement to our women and their youngsters. Thank you, Chairman.
Yeah, that's very, very true. There has been significant improvement in that area. So, you know, well done to all of you who've been involved in that improvement. I know it's been a team effort across the whole service. Patrick, anything you want to mention on any of the quality indicators at all?
I think probably more.
No? Okay, lovely. All right then, thanks very much. So on that basis, I think we will move on. So thank you for the report. We've got an action for a further report coming forward next time. A suggestion about market intervention going forward as well. So can I please welcome to the meeting today, we've got 3 people, one from the listening lounge, who is Chris. Do you want to come forward, Chris Shelton, Mike Polframan from the Jersey Hospice Care, and Patricia Winchester from My Voice Advocacy. So you're very, very welcome to the meeting. So just for background, we, the Jersey Care Commission and their inspection, or a future inspection of the service, looks around various themes about whether the organisation is well led, and one of those themes is working with partners. So hence today we've got 3 partners, important partners with us. They've got 5 minutes each. We've got half an hour in total. They've got 5 minutes each, and we've basically asked the question: what is it that you particularly value about the current system? What could be improved in the system to benefit service users? And how can HCS and your service work better together for the benefit of Jersey residents going forward? So I think if we start off then, Patricia, you're at the end, so we can start off with yourself. Is that okay?
Yes, can people hear me all right?
We will send you down a mic. It's on.
Okay, does that sound okay?
Yeah.
So if we could go to the first slide, please. I'm Patricia Winchester, the CEO of My Voice, which is probably the smallest charity, and many of you will not have heard of it. But the media will have heard of us because we make a lot of noise when we challenge Andy Weir and others about the services they provide for seriously mentally ill people. What I'm going to talk about today is who we are, what we do, what we like about the system, what could be improved, and how can we work better together. Next slide, please. Sorry. Okay, so we're a really tiny team. There's 4 of us, plus an admin support. However, we have successfully won 3 national tenders since 2018 for the service we deliver. Myself and all my staff are fully qualified as independent mental health advocates and independent capacity advocates, and I actually won the National Outstanding Advocate for the Year in 2019. Due to COVID, I kept it for 2 years, which was quite nice. We support between 400 and 450 individuals per year, and on average, each individual will be about 5 interventions. Some are obviously many more, some might just be a one-off. And during those interventions, we talk about their legal rights, their human rights, how they're being treated, what their wishes are, and we help them convey that to professionals who sometimes are not as good at listening, or maybe our clients are not as good at expressing what it is they need. And we make sure that all treatment is fair and dignified. Next slide, please. Just very quickly, you can see that about 250 of the clients we see would be women, about 197 are men, and then 6 non-binary. That roughly, I think, reflects the percentage of people coming through the acute psychiatric wards. In the balance at the moment is more women. Next slide. Again, although we're perhaps better known for working with the 18 to 64 working age psychiatric patients, we do an awful lot of work with older adults, and in particular with dementia adults. And I'm delighted to hear the conversation at the end here about beds for acute dementia care, because we have had people who are still on the ward after 2 years, and clearly it's an inappropriate home environment for them. It remains an acute ward. So we do a lot of media pressure when we feel perhaps our input can actually help. Next slide, please. The type of services we provide ranges from capacity advocacy, which is the box in green. S-role is where people are placed under significant restrictions of liberty, which could be in the general hospital. I should add that our role, we're quite unique in a charity in that our role is statutory, so we are actually set out in the law as having a role that we need to fulfil. We also provide care advocacy. Whilst this is not statutory in Jersey, it's best practice. So we follow care advocacy principles from the UK in terms of largely people with very significant learning disability and complex needs, who perhaps might be living in a flat with 3 or 4 carers round the clock. And we look to ensure that this is about them and not about the carers, and that they are receiving what they need. The blue box is the mental health patients that we see, many of whom are very seriously unwell, but we also follow people through into the community if there's a complex issue, such as a mother who may have been discharged, but as a result of her mental illness, her children are now at threat of being taken away, so we support during that process. And then the red box is safeguarding. We get very involved in an awful lot of safeguarding work. It's shocking the amount that there is in this island. And again, we raise all sorts of issues at those meetings too, to ensure our clients are properly protected. Next slide. The kind of things we tackle about, we challenge, we campaign, we use the media when we need to, and we are above all fearless. So for example, Orchard House, which was clearly an unacceptable facility, I think it might have taken me 6 years to get there, but we have now finally got a decent ward. 2 or 3 years ago, I wrote a very lengthy 11 or 12 page letter pointing out all the Royal College of Psychiatry standards that were not met, which in part I think probably led to Andy being brought over, which has been welcome. Lack of compliance with the law. There was no such thing as a tribunal when I started. There were no lawyers trained. There was no process. We now have a fantastic capacity legislation compliance group. So we don't only have it in place, we're actually monitoring, which is fantastic. We would complain about lack of therapeutic activities. We would raise issues around staff morale. Certainly a big issue within psychiatry has been the high turnover of psychiatric consultants and the impact that having locums has on service, and particularly I think in terms of positive risk taking by those who are in place. For us as a charity, we deal with people who are seriously ill. We deal with probably levels 8, 9 and 10 of psychiatry, and we have felt over some years that there's more political emphasis on mental well-being than on serious illness. And the reason we represent those who are seriously ill is because they can't do it for themselves, or they need support to do it for themselves. So whilst it's nice to look after the middle class, respectable people who have issues, and I don't deny they have issues, what we look after is the people who really are at the very extent of vulnerability. And of course we also challenge lack of parity. What's available for those with physical health can be very different to what's available for those with mental health. Next slide, please. Financial situation, we are on a very tight budget. Because we are statutory, we are entirely funded by the states of Jersey. We cannot fundraise because what we do is a statutory role. Having worked as a civil servant for 10 years, I'm certainly very respectful of the fact that it's taxpayer money, and I'm very careful how we spend it. And our bookkeeping is entirely transparent in terms of showing the commissioners exactly what we spend. They can see how much we spend, for example, on coffee. It's as clear as that. So, commissioning. Next slide. We have an open and constructive relationship with the commissioners. They've described us as a Rolls-Royce service on a minimal budget. Our professionalism and integrity is highly regarded. Working with commissioners helps us develop links with others. It puts us in touch with other services. They also raise ideas sometimes that we as a very small team may not have thought of. So it broadens the depth, the breadth of information that comes to us. Together we work on identifying need, extending services to meet that need. We have regular meetings which are monthly to review delivery. As a service, we've always measured input and outcomes very importantly, and we share those not just in terms of numbers but also in terms of case studies so that they can see the impact that we're having. And for us it feels as if this is a supportive and fair process. Our main concern is the balance of risk, which I'll come on to. Next slide. An example of being responsive and flexible with the commissioners is that when COVID started, obviously it hit us with an enormous shock. We have been asked to develop a continuity plan, which is a new charity. It was not something we had done, so we did that. And as soon as wards and care homes were closed to visits, we started remote working. We also, Patrick might remember, we challenged the vaccination campaign to consider and respect capacity, because the capacity law had only effectively come in 2018, and a lot of people didn't know how to use it. So what we did was we were there with the very first patients on day one of rolling out the vaccination, speaking to care home residents, ensuring that if they had capacity, they had the freedom to make the decision, and if they didn't have capacity, that the right decision was made. This was really vital for you as an organisation for health, because we made sure what you were doing was lawful. What we were finding when we went into care homes, that people were saying things like, Mike should have the injection because his son thinks he should. Carol lacks capacity, when clearly she had capacity. Carol might have decided that all her life she'd rejected vaccinations and she wasn't going to change. So it was very much about making sure that not only were patients respected and they felt listened to, but also your delivery was safe. I think Rebecca Sherrington wrote to us after the programme saying that without us the programme would have shut down on the first day because it wouldn't have been safe to deliver. So this was a nationwide unique thing that we did. Capacity is better understood in the UK than it was here. What could improve? Next slide. It's not equal in terms of risk. So for example, when we negotiate our budget, we were given 3% for inflation, whereas in fact inflation was 10.5%. And we were assured the pay rise wouldn't be more than 3, whereas in fact it was 8.8. Now that's massive for us as a charity where most of our budget goes on staffing, so that's really concerning. We have real anxiety regarding our reserves. You only need to think about the Recovery College to see what happens when you run out of reserves. And our directors are very keen to ensure that we can meet any liabilities as they fall due. That results in a disproportionate amount of time and pressure spent on negotiating financial amounts, which in terms of this board, 30,000 is a very small sum. To us it's make or break. So what would improve for service users? Well, basically, my time is taken away from better developing the service and looking at proactive delivery into doing spreadsheets with numbers and coming up with imaginative ways. And anybody who knows me knows numbers aren't my strength, so it takes a lot of effort. There are also economies of scale that are difficult for us as a charity in terms of IT support, HR, insurance. For example, it costs about $5,000 a year for our professional indemnity insurance, which of course would be a lot cheaper if it could be done as part of an economy of scale process. So certainly we would say that the commissioning for us is a very worthwhile approach. The partnership board is a revised initiative. There was one previously. This one is certainly making much more headway. It's about a positive approach to working openly across public and private sectors and the third sector to deliver integrated care. We focus very much on agreeing need and how we can best deliver that, trying to avoid duplication. This is difficult because, of course, charities in the past have been quite used to keeping their money we're very transparent. Many charities like to keep their funding very quiet. And sometimes I suspect they cross-fund with money they've had for other purposes. And there will be projects which is easier for them to fundraise on than others. So it can be difficult sometimes for my colleagues to let go of their own agendas when we're looking at what's best for the island as a whole. Next slide. Things that hold us back are lack of data. So the amount of data that is held in the island but then not shared is very frustrating. This can lead to a disjointed approach. And of course, there can be insufficient coordination and lack of continuity of care. However, next slide. I'm sorry if it's a bit small. We've developed on this partnership board some island-wide strategies and policies, including the suicide prevention strategy, the dementia strategy, and the neurodiversity strategy. We have a steer for patient-centred services. Now, an example of that would be with the police, for example, who used to pull up all sorts of people on an Article 136 or Article 36 in Jersey, in the belief that they were mentally ill when clearly they didn't meet the criteria. Those numbers have dropped substantially. So not only has that saved police time, but it's also made a better experience for our clients. And that's been through collaboration, Andy working closely with the police, better understanding of what the criteria are, and would you believe, I think the police actually understanding that to detain someone needs to be a lawful process. Sorry if that's not politically correct, but that is how I see it. There's definitely more open sharing of knowledge and information. Sorts of things that have started already is funding for link workers to support social prescribing. We're looking at reducing homelessness associated with admission because certainly within the last year or so, 13 people lost their accommodation because they were admitted to Orchard House and therefore lost their St Andium accommodation, which is a huge issue. My understanding, and please correct me if I'm wrong, is that benefits remain in place for people who are informal, but they are removed from people who are detained. And clearly, that's completely wrong. The fact that you're in hospital wouldn't happen if you were physically ill. Why should it happen if you're mentally ill? We're also looking at developing improved ethnicity reporting. There has been quite a shift in Jersey society in terms of the makeup of the population, and so we're trying to capture that to ensure that we show that we are available for all across the population and that everybody is given the service. And the group that I'm involved in has been looking at developing agreed KPIs to work on a standard service user experience measure. So whilst we measure outcomes and what we believe we've achieved with and for the client, it might be how the client feels about that. You may have delivered X, Y, and Z, but was that actually what was most important to the client? And is there something missing? So that we can look at providing a more holistic response. Next slide, please. In brief, we believe the commissioning process to be fair and equitable. We believe it's based very much on what you do and not who you know. Having been a civil servant for 10 years, I'm very aware that that is the way it always worked, and it shouldn't work like that anymore, quite frankly. It should be on what you do and what you deliver. It's flexible. We are held to account, but so are the states of Jersey. We feel that we're moving forward together, also in terms, of course, with the Strategic Partnership Board. Our main concern is that risk is not fairly balanced. So if we're given 3% when costs are 10.5%, it makes it impossible. And that's it. I hope I did that within about 5 minutes.
Thank you. Your 5 minutes and mine are different.
Sorry.
But actually it was excellent, so thank you very much indeed. It was really, really informative, and I think a lot of us must recognise some of the issues that you've put there, and that whole issue of, you know, being given 3% inflation, and in fact it's 8% that, you know, and the pay rise is what completely with you on that. So yeah. Thank you very much. If we move now on, we'll move straight on if we can to Mike. And then we'll take Chris, and then we'll have a general discussion if that's okay.
Okay, thank you. Mike Bolfren and Chief Executive Jersey Hospice Care. I'm going to assume that everyone knows at least something about hospice and Jersey Hospice. I'd like to start by saying I've been here in Jersey 3 years, in post 3 years, just over, and for pretty much all that time we've been working with government on a palliative care and end-of-life strategy for the island. It's the island's first palliative care and end-of-life strategy, and I'd like to pay credit to the parts of government we've worked on with this, because I think it's an excellent strategy born out of real collaboration and partnership, and we've built an excellent relationship with Jo Pointer and her team, so I'd like to start by paying credit to that. That strategy has also brought in more money into end-of-life care, which is excellent. It's given hospice the chance to get more money for existing services that were poorly funded by government prior to that time, and gives hospice more sustainability. And we're also currently working on new services to further expand that strategy, at the end of which we're hoping that we will end up with a 3-year contract where the funding, government funding for the total, will amount to about 44% of our total service costs, where by the same token, hospice will continue to fund 56% from our fundraising and retail activities. And that for me is certainly a far better balance than the 18% that it was when I first came. Recognising that we have strengths in fundraising and retail, but nonetheless it's a tough market out there, and cost of living and whatever. So I guess my point in all of that is, for every £1 government is investing, you are getting more than £2 worth of value for what is an essential health service. And it, as I say, it gives us that certainty. I think everyone is clear, both in the areas we're working with and others that the success of this end-of-life strategy is critical to Ireland. It's critical anyway with the ageing population, and it's even more critical because of the advent of assisted dying, where we all want to ensure that there is real, genuine alternative. So we're also very clear that the next 3 years while assisted dying is being worked up, we need to end that 3 years with the best possible palliative care and end-of-life service across all areas. That partnership with Joe and team over time has been flexible. It's been one of debate and negotiation around targets and KPIs where there's been a willingness to be flexible. We've certainly been part of a detailed planning exercise with them and other stakeholders on the end-of-life partnership group. And yes, it's contained some fairly robust and at times challenging conversations around money and inflation. I'm going to come back to inflation. So generally speaking, along the way, we've ended up we believe, in a very good situation, and one that is one of genuine partnership. 2023 was a challenging year, I'll be honest. It took the best part of that year to agree the contract with hospice, and there were various challenging situations, and there had to be some give and take at the end of the day. But yes, at times we weren't happy, at times commissioning weren't happy, but we ended up in a good place. But I think what that brought to mind was that when it comes to contracts, there needs to be consistency. I think in our particular case, this was a first timer, so whether it needed 11 months to get it sorted, I don't know, but there were always going to be challenges. Hopefully that contract will now be a template for others. I'm going to end on inflation, and that's the one I particularly want to push, picking up on Patricia's comments. Hospice ended up bearing the brunt of inflation across 2023 and 2024, bearing all of it, I should say, because our initial contract didn't include inflation. And over those 2 years, the inflation was probably around about 20% cumulative. So that was a big drain on hospice. We do believe we've now got a situation sorted with Joe and colleagues where inflation will be covered going forward. So that is a step forward for hospice. My understanding is that most third sector and other providers out there do not get inflation in their contracts. If you're looking at the third sector, the voluntary sector, we mostly, not all, but we know how to operate on slim budgets. We know how to make best possible use of resources. I suspect we can teach government a thing or two on that. To expect those organisations who are contracted with to cover inflation is very unfair, inappropriate and self-defeating. So my biggest improvement and plea is for all providers going forward, you need to look at providing inflation in the contracts. And that's me. Thank you.
Thank you very much for that, Michael. There's some themes coming out already, so Chris, I'm sure you'll continue with those themes. Thank you.
Thank you. And yeah, mine's short, so I'll the time Patricia gives me. So I'm Chris Shelton, COO of LV Care Group, of which part of which is the Listening Lounge. So I believe I'm here primarily to talk about the Listening Lounge and the tendering process. Happy to do that, but also very happy to talk about what kind of wider care economy, which we're heavily involved in as well, if that's of interest.
Yeah.
So the Listening Lounge was a service that initially began as a pilot in 2019. It was a collaborative work between ourselves and the government. It identified a lack in the market for early intervention in mental health. The process from the beginning was really collaborative, and I think both sides came out of it with a lot of positivity. The service launched, and we feel was very successful. It took a lot of pressure off talking therapies, which allowed them a lot of space to grow. And obviously, we've had very measurable, deliverable results that have greatly worked for the mental health of the people in Jersey. We feel. So kind of jump around a bit, but I would say we started in 2009. It was supposed to be a 1-year pilot. It's just finished. So and we've now gone to a full tender process, which is that's obviously there's been a fair few things happening in the world in that period, including COVID. And during that, again, we really felt collaborative teamwork, both sides putting together. Let's just make this work. And I think that's been our approach as a business: is always try to be open, always try to share our workings. We want to be clear, and also trying to understand from the government's point of view what's achievable, what's desirable, frankly, what kind of money there is to make those things happen. And then we can all have a frank and simple conversation about if it's doable, and if it's doable, then we'll try and do it. So it's worked well, I would say. Similar to both people before me, it wasn't inflation linked. So in 5 years of wage increase of at least 20%, I would say, over those 5 years. By the end, it became a bit challenging, I think, to deliver the same quality of service. But maybe commercially that was on us, I don't know. But there was government reasonable, health department reasonable about making changes when needed, and flexing the service when needed. And I think our experience of this tender process that we've just been through now was, I think, really positive. I'd like to think that the longer you work with the health department, the more trust builds, and then perhaps everyone feels a bit more comfortable sort of sharing a bit more about the actual drivers and motivations and what's possible. And that, I feel, with regard to the newly designed listening lounge, it's slimmed down, which is clearly commercially is beneficial to the government, but we don't feel it's slimmed down in terms of the impact that we can make. And that's because I think everyone, after the first initial meeting, sort of decided to just open their workbooks and let's all get together and let's see what's possible. I mean, as I say, we're a Jersey company with Jersey founders, and we're very interested in our island and improving the quality of it and leaving a legacy for it. So clearly want to make money and be commercial, but we also want to improve the quality of life for people in Jersey. So I think that's great. I will say that we've been doing it for 15 years, and it's taken quite a while for us to get to that kind of stage, which perhaps that's just how it goes, I don't know. But I would say, as a more general comment, most people that I know in the private sector providing care are highly motivated and ethical people, and as are on the other side too. But I think perhaps it could get a bit more trust straight up the bat. I would suggest. What else do I have to say? So I think key for us in all the things we do is measuring results, and we know that's key for the government, and the health department. I would suggest that there's a lot more that could be done there. From our point of view, we're very hot on it. We are primarily a commercial animal. Everything we do has to be justified. Every penny we spend, what's the benefit? If we're investing in X, what's the outcomes, etc., etc. I would say, not as a criticism, but I would say government has perhaps struggled to collate a lot of that information holistically, and it's always felt to us that there's a massive opportunity to collate holistic information on a small island and a small data set. It should be so much better, and frankly, we've always felt that there's so many potentials for smarter working, saving significant budgets, and actually more people talking to each other. That's the kind of perhaps on the side. How could things get better? First comment to say is they've definitely improved, I would say, over the last couple of years. Communications definitely, consistency. It would be the one thing, as a private provider, the one thing we would ask for from the health department and the government in general. It's a consistent message, which we can then plan around. If you're talking about, as I walked in as you were talking about dementia, so I'm digressing slightly, we're talking about dementia strategy and what have you, and all these kind of long-term plans. Obviously they're very expensive. So, I think as a company, we've invested more than £60 million in Jersey over the past decade. We'll happily do it, but the payback on that kind of money is not instant. So, it's very concerning to us as a commercial company if someone says, well, here's a new plan for the island. I think we're on the third now in my 15 years. And I appreciate, things change, you could come in, ideas come, but it's very, if you're looking to commercial entities to commit large sums of money, for example, we do currently have a large dementia facility that's had planning approval passed in Blackdown. That's a £35 million build. So, we're delighted to do it, and no doubt the island needs it, and it's going to be a real positive for the island. But, you can understand how, especially in these challenging financial times when interest rates are tougher, that if you're going to try and make those business cases, justify it, and raise the funding, the people are rightly going to ask those questions. Is this need going to be there? Is the partnership still going to be as strong? So, I'm not saying it's not there. I'm just saying that perhaps that could be strengthened, and perhaps something that would allow all commercial partners, not just us, allow them to be a bit more confident about going forward. Yeah, I mean, that's it. I mean, other than to say, as a commercial entity, and we've always felt there's much more that could be done. We've got good communication lines now, but we'd like to suggest more. We feel that there's still perhaps a small degree of us and them between the commercial sector and the health department sector. Neither side's right, but both, we both have good ideas, we both have good opinions, and with more collaboration and more openness, and I think that will get us to where we want to be.
Right. I thought that was brilliant, actually, and whoever chose 3 such different organisations in terms of scale, type, and indeed private, completely wholly government funded, partially government funded, did a really good job in making that choice. So thank you very much, because I think that's given us. But despite how different you are, I think there's some real themes that you've all come up with, aren't there? So obviously you've all mentioned inflation. You've all mentioned consistency, whether you've used the word consistency or fairness, but actually it's the same message really in terms of the government needs to be consistent in the way that it's dealing with people. I was just very taken by your comments there, Chris, about trust, and I think you both implied it, both Mike and Patricia. Yeah, you both implied that issue of trust as well. So thank you for saying it in those direct words. I thought that was excellent to say that, and all said of a process which might be a bit long and can be a bit tortuous, but actually is resulting in better outcomes. And so I think there's some real consistency of your messages there. And then the other thing, which is something which I probably, you tell us, but I sometimes think, government shouldn't interfere in other people's sectors. Well, not interfere, I think you should collaborate, but you shouldn't interfere. And you all talked about shared services, collaboration and doing things, sharing across to make better use of resource on a small island, and how that, I think it would be well worth a conversation about how that can happen and who should lead on that, whether it's yourselves or government, and government is a partner to you leading on it. But I think that's a conversation that needs to be had. And Chris, I'm completely taken as well and agree with you. If you've got to invest £35 million, you've got a return that you've got to make on that. So the whole thing has got to stack up. And when you came in, we were talking about that. Does there need to be some intervention in the market so that the private and the voluntary community sector can flourish in this area? Or do we need to do direct provision? And I think those need to be open conversations going forward, very open and trusting conversations and private conversations going forward as well. So those are the themes that I've taken from that, which I think we need to go away and think about, and definitely think about that issue of inflation, folks, without a doubt. Anushka and Andy, is there anything that you would particularly want to say? And then I'll obviously just open to general comments.
First, so my name is Anushka Miller, Director of Improvement and Innovation. Thank you very much to all 3 of you for coming today. I think that's great. And I must say, I think it reflects very much what Joe and the team would say as well. They are always challenging times, but it has developed so well, and she really enjoys, and the team really enjoys working with, all of you, but also with the wider partnership. So we're commissioning a number of providers, from very large providers to very, very small providers. So very different conversations. And I think where it has moved to is from how it has naturally grown from how it wasn't a commissioning approach as such. It developed into a more wide, we need to put some formal measures in there, but it's moving into, as Mike, you said, we've spent the time on that now, so we can use that as a blueprint and move forward. And I think the emphasis is really on partnership work and using your expertise in service design to do that together, using more data. So I think it's an exciting time going forward to do more for the island. the issue on inflation is absolutely right, and I know Joe is fighting and looking at Mark. It's always the conversation we have to have that inflation in the budget, but I absolutely hear you, and I think we need to think about how we bring this really to the table, because it is internally and being represented to ensure. We always say we get very good value for money from our external providers. No, thank you.
Just on that, I mean, there is such a difference between an organisation from the voluntary and community sector who gets, let's say, £1 million funding, and an organisation that gets £30,000 funding. And I think it's horses. We need to work on the basis of horses. Even though I was so consistency, but we do need to think about that, because it is different. Yeah.
And then just generally, there's also a paper in the board documents about wider partnership working, which is in relation to just giving the board an update on the JCC standards, which also includes where you can see there is a wider partnership working across the system and various different boards and groups, but also we're working more widely with colleagues in Guernsey, for example, and of course in the education space, be it the deanery in the UK, Wessex Deanery. So it is a wide field, and I think that's the beauty of Jersey, having on island partnerships and using that wider across internationally basically as well. Yes, thank you.
So thank you to you all for coming, and particularly for being so straightforward about some of the challenges. I think that I've been here 2.5 years, 2 3/4 years now. The Partnership Board took some time to take off in mental health services. I think it's fair to say there are inherent tensions. There are tensions around collaboration versus competition, particularly in a small place where you only have a small number of providers. And there are inherent tensions sometimes in disagreement of view, and we've certainly had some of those. But actually, I think one of the things that characterises the best partnerships that we have now is the ability to have significant difference of view. In the work we do with the police, I regularly disagree with the senior people in the police. We regularly have to negotiate our way through tricky problems, but actually we get there, and as a result of those honest, open dialogue partnerships, it's much better for our service users. So I think we're really, really in the right direction, and let's just keep it going, I think.
Okay, I'm going to bring in David Keane, who's got a question.
Yes, thank you. Hi. And first of all, that was really interesting as a newbie to all of this. I found that really illuminating, and certainly struck a chord with a lot of things that you see in the private sector in the UK. So it's not, this isn't, I think, unique to the situation here. And I certainly think that strengthening shared services and efficient rolling out of shared services and partnerships is absolutely crucial going forward. But I guess the point I was going to make, more a point I think than a question, was on inflation. And unfortunately, when you have inflation, just everybody loses. I don't know that there is a way to sort of fix that. We're dependent on the macroeconomic world to get inflation down, but I don't think it's realistic to think that inflation can just be sort of magicked away. It is unfortunately just one of those things. It's coming down. It's looking a lot more comfortable in the medium term, but I don't think there's anything that we can necessarily do to negate the impact on partners. I really don't.
Thanks, David. And Mike, you'd like to come back?
Yes, I thought I should just add. There you go. Patricia and I were talking about this the other day. We both belong to a group that meets regularly of charity chief execs on Ireland. Our view and the positive position we put today is not necessarily the majority position. I think I should make that clear. Now, I think we both feel that you get out of partnerships what all partners put into it, and how collaboratively you go into it determines what comes out the other end. I can't comment enough on individual relationships to make a judgment, but it's not all sunshine and light out there.
No, I think we know. Thank you anyway. But it's important. I mean, you're not here to represent anybody other than yourselves, but I think it's really good that you have said that. Thank you. Chris, final word.
And finally, just thank you from me. And I think the points that came through to me was the importance of good commissioning rather than contracting, and about building that relationship is critical. And you're right. Both parties need to contribute to that. It can't be one-sided, and I think what we're hearing is that despite challenges, it sort of worked for us in this regard, and if it works for us, it works for clients. I have enormous sympathy, Chris, with your point around return on investment and the very nature, and it's of course no different in the UK, of the sort of annual budget setting process with government gives little certainty to commercial organisations about what it's going to be like in 2 or 3 or 5 years' time. And inflation, of course, we mention all the time because, of course, we equally have concerns and challenges about the level of inflation that we secure, because we know that medical inflation, whether it's on drugs or on the contracts that we have in the UK, always exceed the level of sort of inflationary lift that we enjoy. But that has to be resolved, to say that small charities and all are small compared to the size of government, it has a great impact on what you can do and what you can't do. So, but I would like to thank you, and we do recognise that those partnerships are not absolutely perfect across the piece, and that needs to be worked on and developed. So, but I do thank you. It was interesting.
Yeah. It really was, and it's been a great value to us, so thank you very much indeed. And I have no doubt whatsoever that the people who don't have such a positive relationship would only have raised the same issues that you've raised anyway. I always say to people, it's easier to hear when people aren't shouting. And, so we're often told, that you're not listening, but actually some people aren't talking. Do you know what I mean? So I agree with you absolutely 100% with the point you've made. You get out of a relationship what you put into it, and that's both sides. So we've got to really put into those relationships really constructive listening and collaborative behaviour as well. So hopefully that's a commitment from us as well.
We both shout coach.
We all do, but anyway. Okay, well, thank you very much indeed to you all. Really, really appreciate it. So I think if I can pass over to Ian to introduce the report. What I would say in relation to the workforce report, this is different than what people have seen before, and so I am sure, Ian, you will help explain some of that. Thank you.
Sure, thanks Chair. Just a couple of things before I go into the workforce report. I just wanted to recognise, it's in the Chief Officer's report, but actually we're a very small department and we've had some significant sickness from some very key members of staff. I want to just recognise the support of the exec team, but also of Leslie Darwin, the Chief People Officer from Government, to support us during this difficult time. That's really important. And the other thing is I'm really pleased about recruitment and just really underline the partnership between nursing and HR in achieving that. It's been a really great working with Jessie on that. So I'll move into the data report, if I may now. You'll remember, Board, that we withdrew the report from the last board. There were a number of reasons for that. I was relatively new in post and hadn't had really a chance to do the due diligence on the data, and there had been a problem at a previous board where we had an error in the data that we had to correct, so we didn't want to put the data out until we were able to stand over it. So this data report is the first in what I hope will be an iterative improvement in workforce data. And I know the People Committee is already receiving more data, and I know Caroline, as chair of the People Committee, you'll talk about that later in your report. So the main changes in this report is that it's more of a dashboard report, and it gives more information on where the data comes from and what the data is telling us. So there are data labels on it. There are some warning signs about this report. Our business intelligence people have to draw this from multiple sources, and when you're doing that, there's always the risk of error. And there are still discrepancies between our finance and people ledgers, and HR and finance continue to work to reconcile those. So there are some warning signs around this report. I'll just talk about some of the headlines, really. The report on new starters, that reflects the high level of recruitment that's been taken since mid-year, and obviously you can see there's a dip in August because everyone went on holiday, but other than that, recruitment remains at a high level. Underneath that data really is the story that actually our time to recruit, which isn't yet in this data, has sadly gone up a bit. So it's taking us longer to recruit slightly than last year. But when we look under that data, last year we were mainly dealing with internal recruitment, so people just moving ward to ward. That now we're bringing in many more people from outside, and that takes a bit longer, the checks take longer, etc. So it's sort of a good news story, even though the metric of time to recruit has gone up a little bit. The reduction in vacancies obviously reflects what we're doing in recruitment, and then the turnover stat is quite difficult. Now this was one that we've talked about before. At this stage we're not able to express turnover from HCS because the Connect system is a government-wide system, so what it records is people joining and leaving government rather than joining and leaving HCS. So we're working with our business intelligence people to see, because obviously we're interested in what our local level of turnover is. That's an important stat for us to look at, but we can't talk about that at the moment. When we talk about sickness, so we're fairly confident that sickness is running around 6%, and you've had a previous paper on that, exploring benchmarks, etc. And 6%, we would say, doesn't really particularly give us an immediate issue for attention, but it is something we keep an eye on, and we have been doing quite a lot of work on particularly long-term sickness. So we've undertaken a review of everybody in the organisation that's had sickness over that we class as long-term, working with line managers to make sure those people are being properly supported and that they're getting the proper support to get better and get back to work. On the staff costs, so the overtime spend is reducing in year, which is good, but it's still higher than in previous years. And the increase in basic pay, you can note from the stats, is about the increase in recruitment with the offset of reduction in agency spend. And the reduction in agency spend has been really significant, as you've already picked up. We're really being quite successful with that. And as we get more and more agency staff leaving, one of the positive things are a number of the agency staff that have come to Jersey as agency staff, like Jersey, like working for HCS, think it's a much nicer place to work than perhaps where they've worked previously in the UK, and are now looking to join us substantively. So that's really, really positive. The 0 hours stat, that's our bank stuff. So we don't have thousands of people, we're not an exploitative employer with thousands of people on 0 hours. What we have is a number of people on our staff bank. A lot of those are our own staff who do extra hours through doing hours on our staff bank, but there are people that only have a bank contract with us, so that relates to that. When we look at connected performance, so this is the level of objective setting and mid-year reviews that we're doing as recorded on the Connect system. Now this is low, and I think it's an area that we need to pay attention to now. There are some issues. The implementation of Connect, the training for Connect and the actual implementation of Connect was a little bit big gap of time between that, and I think managers have sort of forgotten how to do it a bit. So I think there's a competence thing about managers being able to engage with the system, but I think there's also an issue about managers' compliance with appraisal that we need to work out. And the final thing I'll talk about is just the My Welcome. Just to be clear that My Welcome is the Government of Jersey induction, so welcome to the Government of Jersey as a civil servant, doctor or nurse, rather than our local induction. So we do need to build stats for our local and indeed team-based inductions. So the dashboard is where it is now. We've had one workshop with colleagues from all parts of government joining us to help us look at that data. We now have a series of work streams looking at a series of different workforce data. So my expectation is that as that work stream delivers, this will improve for you at each meeting in terms of the breadth and depth of information that we can show the board. But the important thing there is that it's not just about the board, it's about that we provide this reporting at directorate, care group level, so that actually we give our managers the information to allow them to manage. And that's the main important. It's important for you to see it for assurance, but it's more important almost that managers have it to allow them to manage effectively. So that's all I'll say about that, and happy to take any questions. Thank you.
So we did have quite an in-depth conversation yesterday about this very same report at the People Committee, which was probably more appropriate at that committee for such in-depth, in such detail. But I just wanted to say that, this is the first time we've been here as non-execs for a year, and I think this is the first time we've had this quality of information in that year. And again, to say thank you, a really big thank you. I mean, it's not there yet, obviously, but it's absolutely moving in the right direction, and I genuinely feel that with this better quality of information, then we will be in a better place to, ascertain what is and what isn't going on in the whole directorate. So you mentioned the issue of the Connect, you call it Connect here, appraisals.
The personnel system.
I mean, I have to say, folks, I think it's really shocking. Really, really shocking. And I get that some people, might not be able to upload the system, and actually they are having proper performance conversations and development conversations with their staff. But actually, if you look at the number of staff, which is very low, 19.3%, who have done their mid-year self-review, but only 7.4% of managers have effectively responded to that. That's pretty poor. In fact, it's not pretty poor, it's terrible. And I think, really, you've got to get a grip on this, and you really, really have to start ending up with a much better statistic. So I know that Jessie, in nursing, the nursing statistics are good. So somewhere, therefore, if the nursing statistics are good, somewhere they're really shocking. And so I without wishing to overemphasize the point, I do think this is an area that we've just got to get a lot better at. And I completely, having been a manager for donkey's years myself, I know it's a bit of a pain writing up and putting on bloody clunky systems all the detail that you've got to put on, and it doesn't mean that people are not having appropriate conversations, but actually you've got no evidence without this to say that that is all happening, and therefore we've just got to get on with it, really. So that's my plea, really, that we really sort this out and we just get better on it, if that's okay. So sorry to be a bit school-marmish on that one, but
you're right, yeah. Chair, that again, people are having the appropriate conversations. We've got the system, we can. Connect is the system. We've got to make sure that managers use it and not just have those appraisal and objective setting conversations and writing it down on paper, which has been the old way, but actually transpose that into the Connect system. It does take time. I've obviously set the objectives and do mid-year reviews for all my directors. And it's not a quick process, and maybe I'm just incompetent at using the system, but it doesn't feel particularly quick. But nevertheless, it is the system. We will get better at using it the more practice we have. But having those conversations, as we know in nursing, Jessie, those conversations take place. But for a ward manager who's got 30 perhaps staff to appraise and do mid-year reviews, transposing those 30 staff onto the computer system is a significant task, but it's one that we've got to do, unfortunately. Yes, that's the system.
Yeah, I think sometimes there's got to be a bit of give and take on this as well, that so some of these systems are just not appropriate for the kind of, if you're doing a clinical appraisal, a clinical discussion, etc., they're just not really things. I mean, can you not just write it up or type it up and then just append it on the system? I know you can't, but I mean, it would be ever so good if the system was adapted so you could, because what is right for the majority of civil servants is probably not right for the majority of clinicians, to be absolutely honest. So there's got to be some give and take on that, I think. But whatever, we've got to get better.
You need to make the point about doctors who are very special.
Doctors are even more special.
Doctors are very special. Doctors are not appraised through this system. No. There's a separate system, and because it's part of our regulatory responsibility and you can't revalidate and relicense without it, doctors' appraisals tend to be a bit higher. But the system is much more fit for purpose as it's designed for medical appraisal. But just to make the point, doctors are not included in these figures.
No. But that makes the point as well, doesn't it? That if you've got to do it because you can't practice without it, it gets done as well, doesn't it? So it makes the point two ways. Andy, I know I can tell you've been chomping at the bit.
So just for clarity purposes, the 25.8% of people that are at the year-end self-review have completed, I mean, you have to complete each step moving forward, so it's cold comfort, but it means that it's actually 26% plus 8%. I would like to see a more detailed report, because I think this data, we tend to have some difficulty with consistency around it, and certainly the most recent reports I've been receiving for the services I'm responsible for are indicating that managers are at 75 and 80% compliance. So, and I doubt that that's not the case in other places, so it would be really helpful to see a more detailed breakdown, I think.
Okay, fair point.
And yeah, just to clarify, this data excludes medics because they're on a bespoke system. It also excludes manual workers because their contract doesn't require them to have appraisal. And picking up Andy's point, I have asked for them to run reports by care group and indeed units below that, so we can start getting more forensic on the data. So that's part of the data cleansing and work that we're doing. So that work is already underway.
How do manual workers there have a proper development and conversation with their line managers?
I'm afraid I'd have to say they don't.
But that's terrible.
But it's contractual.
But it might be contractual that they don't have an appraisal, but it's not contractual that they don't have proper care from their line managers, surely.
I obviously am quite new to the manual workers contract. In my discussion with our union colleagues and with the leaders of those groups, anything that looks like it may be an appraisal conversation is declined on the basis that it's not.
So they don't get any development opportunities at all, manual workers?
They do, but I think it's done in a more ad hoc way.
On Claire.
Sorry, I haven't got. Thank you. I suppose just to reassure, so whilst there's not a formal system that the head of non-clinical services is using through his department leads, we do have evidence of where those staff are climbing the ranks, so being developed, having access to the particular technical courses, particularly a lot of those, whilst not they're within the manual workers group, obviously a lot of technical expertise, so we're talking about people in our estates, catering, water safety, elements of health and safety compliance, and people moving through. So I think we do have evidence of that, but obviously there is that really specific element of how the process of appraisal is viewed, and therefore they're not included in that system. But I think we can say that we are developing those staff, and a lot of those staff also stay within the organisation for a very long time.
Well, they will, because they don't have a performance discussion anyway. Okay, well, thank you very much indeed for all of that. So we'll keep working on it. It's really, really good. Really, really good that we're moving in the right direction. And Andy's right, everybody will have their own different stats, but we can't just not produce anything on the basis that everyone's got different. So thanks very much indeed for that. And we'll move on now. And so the out of hospital and health and care services was a request that report comes forward, and I think we just got that for noting today, if that is okay. Is that all right? Tony, or did you want to say something? You look like you did want to say something.
Can I just make a quick comment?
Yeah, you need the mic.
Yeah, very quickly, Chair. Yeah, I mean, this is a very important initiative that we want to keep up really live in the board for all the reasons that we know about ensuring that hospital is used for people who need to be there, in terms of admission or not being discharged, really. Andy, you and I were talking about sustainability and supply of services which can enable people to be properly supported safely and comfortably outside hospital. So, and the Lang and Whistle report as well. So I just wanted to want a quick update as well on that, if that's okay, Chair, very quickly.
Yeah, thank you. Certainly. So there's a piece of work that's been going on led by Customer and Local Services, looking at our arrangements around particularly care packages and care in the community and how that's funded. and how we utilise that. And we've been heavily involved in that, particularly in the form of Paul Rendell, the Chief Social Worker. That piece of work is near to completion. I think that will help us in terms of thinking about standardised rates, in terms of thinking about future need, how we manage those arrangements moving forward. There is, as I've indicated earlier, a clear tension here. You know, there are occasions when we could purchase much more expensive care for people, but then we'll be setting a precedent around rate and managing demand, and that then becomes a tension in terms of managing our financial sustainability within HCS. So this is the dilemma that we're facing in terms of moving that work forward. Clearly, we've already referenced in earlier discussions today the work that needs to happen in terms of particularly stimulating the market, I think, and particularly making sure that we stimulate the market for the right group of people. We hear sometimes, but there are beds available, and sometimes there are beds available, but they won't take the people that we need them to take. When we talk about development of services for people with dementia, there's a really clear unmet need for people who have the most complex needs. We need to stimulate the market in that area and make sure, and this comes back to the commissioning conversation, I think, so in almost many ways this brings together a strand of a number of the conversations that we've been having this morning. We need to be clear about what we need, how we then want to commission that, and how we engage with the market in delivery, but delivery that is affordable.
Great, thank you very much indeed. So we'll move on. Just trying to manage time, because I don't want to have to in any way squeeze the time for questions from members of the public, to be honest. So we'll just keep moving swiftly through. So the next item, again, is largely for information, which is about ADHD. Are there any issues that anybody particularly wanted to raise in relation to that? You did, I think, didn't you, Tony?
Yeah.
Yeah.
Yeah, a couple of questions, Andy. I mean, firstly, is there anything happening in other jurisdictions which can be of benefit and help here? And while, also, the report makes reference to work that's taking place about ADHD medication on the prescriber list for primary care and community prescribers. Also, potential joint work with a private provider, introduction of electronic self-assessment tool, and development of sessions from GP with a special interest. So that's work that's going on. So I think we'd all be looking for updates on that, because this is such a critical and growing issue.
Yes,
certainly. Yeah. Thank you. So, in terms of other jurisdictions, deliberately I referenced in the paper that there's been a recent article in the Health Service Journal in the UK indicating waiting times of 7 years for outstanding mental health organisations, and indeed the longest NHS wait is 10 years now for an ADHD assessment. I'm not articulating that just because it's cold comfort. I'm articulating that because we need to understand that this is an international issue, and we are therefore in competition with all of those providers elsewhere who are seeking to solve this issue. So when we talk about specialist skill acquisition, for example, and recruiting people with specialist skills, there are lots of people fishing, and that makes it more difficult to solve the problem. There is a piece of work that's been commissioned by NHS England, being led by the Royal College of Psychiatrists, looking at what can be done about this problem around the ADHD waiting list, and I'm pleased to report our ADHD consultant is engaged in that work, he's leading that work jointly. So I'm hoping that something will come from that. Where we are now then, we still have an unresolved issue around shared care. We've talked about that here previously. I'm very clear, one of the things that we could do is we could seek to commission private folk to come and undertake assessments for us. That's one of the things that is being done in the UK, although in fact many of the private providers are also closing their waiting list because there's so much demand now. However, as I set out in the paper, if we do that, then we'll have even more people that we need to prescribe for, and we don't have the capacity to do that. We currently have 254 people who are having to have monthly prescribing, and this is worsened by the shortage of ADHD medicines, which again is an international issue. So again, I'm afraid to say I don't think there is an easy solution here. We're still working on the shared care arrangements, because that would free up time of our specialists to assess and provide specialist advice rather than repeatedly writing repeat prescriptions. We've rehearsed this a lot. There's a scrutiny review currently of the ADHD prescribing arrangements, and we'll hear what they have to say about that at the end of their review. We are in conversation around a potential private provider and an electronic self-assessment tool. It's a very, very early doors conversation about how do we make that work in the context of everything that I've just described. And of course we are still talking jointly with GPs about can we move forward the shared care arrangement, because it seems an obvious potential win in terms of available capacity.
Right. Thanks very much. Thank you. Thanks very much for that as well. So we then have the board committee reports, and I think actually because the People and Culture Committee and the Finance and Performance Committee only met yesterday, we'll bring those to the next meeting as written reports. So just therefore the Quality, Safety and Improvement. Tony, you were at that meeting, weren't you?
I was speaking on behalf of the chair of that committee, Claire Adder, who's not here today, was given apologies here. We're asking the board to note that there have been a significant reduction in pressure trauma acquired in care. That's evidence of some real improvement. Serious incidents, all open serious incidents, have allocated investigators. There have been some cross-cutting themes identified from the range of recommendations, which is good. So things not being seen simply as single things to sort out, really. And the range of improvement plans bouncing off that, so that's good, really. CAS alerts, the committee's aware of a large number there are a lot of overdue alerts at the moment, but we were assured in the committee that they are being triaged on receipt and no serious issues have been addressed. So that is being managed, we were assured. Policies, approximately 50% of HCS policies are overdue for review, and this is becoming a regulatory issue within learning disability services. So there are various recommendations for improvement there, as a number of corporate policies are actually out of date. Noted the absence of a paediatrically qualified designated doctor. Cathy, you might comment on that, I don't know. On the CAMS service, and as you've said many times before, there are 140 children held by CAMS who really should be being transferred into adult ADHD services now. And finally, pharmacy review is making recommendations which relate to island-wide issues, so we do need the support of other government departments, not just HCS. So I don't know whether anybody else wants to comment on that.
Jessica, of course, Jessica.
Is it still on?
Yeah.
So although the designate doctor is not paediatrically qualified, he does have the qualifications to undertake the role, so we do have a designate doctor within safeguarding for the island.
Okay, thank you. That's helpful. And Patrick, here you go.
Sorry, I'm just on the CAS alerts. There has been somebody going in temporarily to try and look at the backlog, and they've made really significant inroads into that. We just need to see if we can make that a more permanent, but that position has improved.
Oh, good, excellent, good. Lovely. Well, thank you for that, Tony. So we'll now move on to the pharmacy report. Now, this report has been made public previously, but I think this might be the first time that the action plan has been put in the public arena. So, who is this you, Patrick, who's presenting this one? Okay, cool.
So my deputy Simon West was desperately trying to finish his clinic in time, but I suspect he hasn't managed to do that, so I'm very happy to bring it to the board's attention. I will take it as read. There was a review of our pharmacy services recently. The report has been published, the action plan is attached, and they have made 59 recommendations that have been divided into culture, workforce, workload, education and training. We've received this report relatively recently, so the action plan is evolving, and in particular on how we're going to organise ourselves to deliver it. Work has already started. I know there's been meetings around culture and a plan to address that. That's one of the areas we really want to focus on. We're looking at the way that the pharmacy is structured, because there are some really regulatory and governance parts of the service. and then the more operational parts of the service and looking at how they function. One of the things that the report highlighted was just how difficult it is to address both of those in the way that the department is set up at the moment. The pharmacy department is a little bit unique in that it has a regulatory function outside of HCS. So, for example, the chief pharmacist is responsible for inspecting community pharmacies. They have a responsibility around a lot of the drug or involvement in drug law and involved in cannabis prescribing, the whole cannabis industry, the regulation and licensing thereof, which takes up a huge amount of their time. So a paper has come to ELT, which we accepted recently in terms of making some of those changes, and that's to come to SLT for final approval. I'm sure we can report back to the board on that. But as I say, we're in early days, and perhaps we could report back on the progress we make in over a certain period of time.
Thanks, Patrick.
Thank you, Chair. Yeah. I mean, the action plan is clearly very forward focused. No question of that, really. That said, it is noted in the key messages that there are challenges in terms of resource to address those recommended improvements. So it's a question of how we're assured, Chair, that the action plan is actually delivered in line with policy, procedures and so on, really. So I don't know what that process is, but how do we get assurance, really?
Yeah, thanks. I think that's, I mean, there are 59 actions in this plan, some of which, it goes from the sublime to the ridiculous, to be honest, if I'm speaking bluntly and truthfully about it. And, you know, so the chief pharmacist should have a cup of coffee with people, right through to the fact the island needs a completely new strategy for pharmacy. So, I mean, it really is, you know, like a huge work programme. I think it's really important that we do get the assurance on this, that it is, because this has been a problem area for quite some time. And in the public part, we have got somebody who wants us to read out their experience, and that will come down to pharmacy closed at 12, so I couldn't get discharged. You know, there's some absolutely mad stuff in there, really. Well, I say mad, I shouldn't use that expression, apologies. There is some stuff in there that you kind of think, really, is that the right way to operate and to manage? And the coordination between pharmacy and other parts of the hospital, I think is really important, and we do need assurance on that. So I think, you know, well done for getting this report done. 59 recommendations. I personally would be saying which of these really are going to make a massive difference for you to concentrate on, because you've got this review, and one of my comments was you've got this review, you've got the GRIFT review, you've got neurology review, we've got a review of rheumatology, etc. How many more reviews with loads of actions is the organisation able to sustain? So I think just what is really important in these 59 actions, and then monitoring against that would be really helpful, to be honest. But anyway, just my view on that.
No, I agree, Karen. It's I think one of the things when we talk about resource is the level of resource that we've got for the structures that are recommended in the review. So in two respects: one, the numbers of people and the costs of that, and whether we can cover that from our financial position, and secondly, the ability to recruit, which has always been a challenge. So we will need to pick up in the budget setting process for 2025 whether we can actually afford to do some of these things, because I don't think we'll be able to afford to do everything. We will have to prioritise, as you say. So I think there's a resource. Clearly all appropriate processes will be followed, HR processes and all those other things, but I think my concern is the affordability of doing what we would like to do, and to strengthen it. I certainly think that the electronic prescribing system has made some huge improvements in what we do. However, it's resource intensive, but nevertheless a massive improvement as regards to patient safety. But there is something that we will need to pick up in budget setting, which is what can we afford to do, not just in the pharmacy review, of course, but in all the other reviews. There are costs associated with it that we may not be able to deliver, and that's the issue of prioritisation that we face between now and Christmas in budget setting.
Yeah, really point well made actually. So yeah. So when do you think, Patrick, we should bring the next update monitoring report?
I think probably six months.
In 6 months' time. Okay.
I think the other point to make is that we've taken a slightly different approach to this report in that we would normally develop the action plan and have a lot more information, which obviously takes time, so there's a lag between us getting the report and publishing it, whereas this time we've published it early, so inevitably we can't give quite so many answers as to how we're going to proceed. And absolutely, of course, we will prioritise all those actions.
Well, I think what might be helpful then is that our next board meeting we get the prioritised list, and then in 6 months' time we have the monitoring against the prioritised list. Now, I think Chris, well it's not Chris, it might be Tom, but that might be a point for all these different reviews we've got, is just to do some of that prioritisation. Because there's so many actions coming out of all the different reviews that we do. Brilliant, lovely. Good, thank you for that. Anything else? Oh, sorry, Ian.
Thanks, Chair. Just a quick one. Obviously, we've already progressing with some of the structural things, as we've noticed, and we're following the HR process there in terms of doing that. Just one other reflection was, in terms of weekend working, what we have to remember is that we're slightly hidebound by the fact that our pharmacists are on civil service terms and conditions and have no requirement in their contract. So they do the weekend working out of goodwill. So I think we should remember that these people are not contractually bound to do that because of the limitations of the contract, and they're doing it out of goodwill. So I understand it's annoying from a patient-facing point of view, but we've got a bit of a contractual problem behind us. I think I'm sorry I'm being Mr. Contractual today, aren't I? But,
So some of our contracts really need negotiating, don't they, would be the appropriate comment from that one. And presumably I imagine some of those pharmacies could be part of your bank rota.
We resource it in different ways, but it is still down to goodwill.
Or next time we recruited pharmacists, perhaps we could recruit somebody who works weekends.
No, contract doesn't allow.
Oh my gosh.
The matter for the state's employment board.
Sorry, I'll just screw my neck back in on that one.
It is a point of discussion between myself and Leslie as the Island Chief People Officer about what do we propose to the State Employment Board that they should be helping us look at in terms of contracts and terms and conditions. But it's a massive piece of work to start a renegotiation on a significant contract, let alone the manual workers contract. And we've also got the consultant contract on the blocks to be renegotiated next year. So there's huge amounts of work.
So just trying to think creatively about how we do. So if it's a Friday then, and everybody thinks that person is going to be discharged probably tomorrow, could we not get their medicines ready on the Friday rather than, just there's ways around doing these things, aren't there? Yeah. Okay, cool. All right then. So we'll leave it at that then, Patrick. Thanks very much indeed. And then, so our next report is on the GRIF, the Royal National Orthopaedic Hospital, getting it right first time.
So it's actually GIRFT, but
GIRFT, okay.
And just so people are aware who GIRFT are, they are a nationally recognised programme. Now it's been going for 20 years. They come into organisations, really look at your processes and how your work flows through the departments and the way that you work, and then use their experience and expertise from other organisations to make recommendations as to how you may work more effectively, more efficiently, and that inevitably leads to better care and safer care as well. So we looked at orthopaedics and theatres, and the report is obviously attached, and I'll take it as read. There were 36 recommendations to improve productivity and efficiency within orthopaedics and theatres. and these really lie within the care group as part of their business as usual to deliver on those, and that work will continue, and you will continue to have support from the GIRF team, who will come back and see how we're getting on. And I obviously very much look forward to being part of that and helping deliver those changes as from the new year. I think it's important to say we will look to get GIRF back in at some point. We haven't really got a plan or definite times at other services because the advice that they supply is really useful. But we've started with orthopaedics and theatres, and as I say, that will hopefully make a difference.
Sorry, just to say, just a point of clarity, because often people, and certainly in our media colleagues, this review wasn't commissioned because of any concerns about the quality of care in orthopaedics. This is something that I, as a chief executive in the NHS, would use GIRF to look at some opportunities for improvement in efficiency and how we utilise our resources. And actually theatres and orthopaedics is a pretty typical one to look at first, but they do look at all specialties in the UK, so it would make sense as part of our ongoing improvement programme to use GIRF to find other opportunities. But there's potentially some big wins in orthopaedics and theatres as described in the report.
So there were two matters that I need to clarify. So sorry, there were just two things we needed to clarify, because there was a misunderstanding from the report that our MRI scanner didn't have the capability to pick up prostate cancer. It does. What we don't do is screen for prostate cancer, but we do have a facility for that. And there was also within the containment of the report, which unfortunately didn't pick up, a suggestion that there were high levels of performance management within our CSSG department. It should have said high levels of sickness management, which are clearly two very different departments. We've apologised to the department for not picking up that error, but just to clarify that's not an issue, it's around sickness.
Well, actually, there was a lot of positives in this report, actually. Yeah, definitely. But I think there's some, I actually thought this was one of the reviews which actually provided us with some solutions and some better ways of working. One of which, Ian, is the Jersey General Hospital should carry out a review of employment contracts and remove any limitations to allow weekend and out of hours working.
Quite,
just to make a point. But actually there's some very good stuff in here, I think, in terms of improved efficiency. I think the issue which I personally get a bit sensitive about is theatre use and public-private patients, and making sure that public patients are never deprioritised for the use of private work, actually. And I think we just got to make sure that we sort that out. I know that it is our intention to increase, productivity and income, but actually we can't have anybody missing out because of that. Okay, so I think on that basis we note the report.
Chair?
Yes, sorry, Tony.
Yeah, just a quick comment really, that it is worth remembering what Patrick said, that the reviews are not always because things have gone seriously wrong. I mean, we have had some of those, of course, and we'll always be open in how we address those challenges, but a good organisation does encourage reviews periodically of all its services for that freshness and what we call some groupthink. So it's worth emphasising. Thank you, Chair.
No, absolutely, I completely agree. So, we then come to the board assurance framework. Emma, is there anything you particularly wanted to highlight?
Thank you. So just as a recap, obviously we've got our board assurance framework, so that supports our understanding and management of the risks that impact the delivery of our 2024 objectives. Our committee agendas are drafted and constructed so that we gain assurances around the key controls detailed within the BAF. It is a fluid tool, so in conclusion, really, after our most recent round of senior meetings and the committees, one of which happened last month, and People and Culture and Finance and Performance yesterday, Quality and Safety and Improvement Committee, so they reviewed their relevant elements, that included patient experience, and there was agreement that the risk for quality and safety remained at 20, patient experience at 8. The two committees yesterday reviewed their relevant sections of the BAF as well. So, as we've heard really, finance has increased to 25. Obviously, the risk of achieving the other objectives then increases across all domains, so we'll need to kind of keep a close eye on that as we move through the remainder of the year. In terms of people and culture, the general conclusion from the committee was that the risk is probably higher than the 16 that it is at the minute, but an action was for the Director of Workforce and myself will do a review of the actions and assurances, in particular to align with the priorities that were agreed following Ian's appointment, so that work will carry on and will be concluded by the time of the next meeting.
Right, and then do you want to talk about the declarations of interest?
That's just there for information.
Information, okay, brilliant. Lovely. Thanks very much indeed. So I think that brings us to the end of the agenda for our Part A meeting. It's now 12:04, so that gives us 25 minutes in which we can take questions from the public. So I know there's a gentleman who's been very patient waiting. Can we pass down the microphone from there? Thank you very much.
Hi. My name is Trevor Krause. For context, I'm the Senior Director of Change and Transformation in the finance industry, and specifically for Royal Bank of Canada over the last 35 years. I have a breadth of experience not only working in Jersey but across British Isles, Asia and Caribbean. I have a specific question that I'd like to address to the board. At the HCS Advisory Board meeting held on the 30th of May 2024, and subsequently captured in the published minutes on page 11, a member of the public asked if a zero-tolerance approach would be adopted for bullying, either generally and/or of whistleblowers, as it had already been publicly stated would be applied for instances of racism. Chris Bown confirmed that HCS has a zero tolerance of bullying. He continued with the following statement: "There must be evidence of bullying, and upon investigation, it is not always the case that bullying has occurred." His last sentence is perfectly understandable. However, if, following the completion of an independent investigation executed in alignment with the applicable policy, certain and specific allegations of bullying are indeed upheld and fully substantiated, then what does the application of zero tolerance actually mean in practice? If your interpretation of zero tolerance does not support a one strike and you're out approach, then what lesser approach is applied to the guilty employee? And does the board believe that the cessation, preferably, or curtailment, the next best outcome of bullying and harassment, will be adversely impacted and diluted if confirmed bullies are allowed to continue benefiting from their employment with the Government of Jersey, and not seen to have been suitably disciplined and penalised whatsoever due to the fact that any actions recommended as part of the investigation are required in accordance with the policy to be kept confidential? That sounds to me very much like the bully winning again. It is absolutely imperative that when allegations of bullying are substantiated following the completion of either an internal or external investigation, suitable and swift action must not only be done, but also be seen to be done. Thank you.
Thank you, Mr. Oh, can you hear me? Yep. Mr. Bryce, I think we know what we're talking about. We've corresponded on email. All I can say is that due process will take place. That is something that I committed to, as you rightly say. That process and the outcome of any investigation is reviewed by a panel, a disciplinary panel, and that process will be followed through. And I don't intend, and never will, discuss individuals publicly. Thank you.
So thank you very much for your question today. I think it was Jean Elliott who asked the original question, which Chris had definitely answered at the time. In terms of the wider implications of what you've said, I mean, do we think that bullying is inappropriate, unacceptable, and does harm performance? The answer to all of those is yes. And Chris has answered further in terms of that due process will now be followed, whether it's an external, it has to be, for legal terms, there has to be an internal process between the employer and the employee, and that will take place. Thank you. Okay, so now, and I've not got anybody else with their hand up. If anybody's got a question, please do. I do have another lady who has written in this morning who would like to have her statement read. She's actually in hospital, so can't be here, but she does want to have her statement read out. Emma, are you okay to read out her statement for us? Thank you. I mean, I've read it, and we really need to listen to this.
Okay, so I'll just read out this verbatim. I would have attended your meeting at 9:30 today were I not temporarily in the general. So please can you use this email to put before the board today? For this I thank you. Please use this email of my direct experience over the last 3 weeks to bring about change. Effective communication is essential and does not cost anything. But could this problem be as a result of pressure on your administrators as well as caring staff? Anyway, it does not need more money, just attention to the job in hand and training. I have currently been at the General Hospital in Beauport Ward and now Plemont Ward following a fall and under observation since Wednesday the 4th of September. I have had plenty of opportunity to observe how management of the hospital operates and its part in bed blocking. Firstly, I must give credit to extraordinary care and compassion I and my roommates have without fail received from the caring staff. They deserve every penny and more of their wages. The pressure they are under from not only the amount of work over long hours, but emotionally cannot be underestimated. However, as for administration, the left hand does not know what the right is doing, and that, from my observation, has been a factor leading to the current bed blocking of the 32 beds. I have not seen that listed as a contributory factor so far. Example 1. Last week I was due to have an MRI scan tomorrow. No timing or any indication of morning or evening, but I'm not going anywhere. I did not dress that day as it is difficult for me, and anyway I needed to ensure I was not wearing knickers, so no need to dress. I waited from 8 o'clock in anticipation until 12:15 when I dressed, as I did not want to be in my nightie at lunchtime. At 1:15 I was told I would have the scan at 2 p.m. So I undressed, and as usual with difficulty, but I did not want to add to the staff's busy day, and anyway I could do it myself. The porters came with a trolley at 1:45 when the junior doctor, who had been in the ward all morning, realised I had not had a cannula inserted. This took 15 to 20 minutes. This could have been done at any time during the morning at leisure, and not under pressure from the busy porters who chivvied him on. When we got to MRI, I was told they'd been waiting for me and had been available earlier on, so their expertise and 2 porters had been wasted and timely progress was interrupted. Example 2. When I arrived on Portlet from Beauport on Saturday the 15th, there was a charming, bright roommate about to be discharged that day. She told me after waiting during the day that they could not discharge as they had not got her prescription to pharmacy by lunchtime when it closed, so her discharge was delayed until Sunday. Everything at home had been arranged. On Sunday she was told the doctor had forgotten to sign her prescription, so she was delayed until Monday. I don't know what happened on Monday, but she was eventually discharged on Tuesday afternoon, having been in the bed for an extra 3.5 days. Of course, it may be there were other reasons for her delayed discharge, but she was not told that. Example 3. Yes, me. After 3 weeks under observation and being told I was due to have conductivity and EMG testing yesterday, and getting great store by these tests for many days, I was told yesterday morning that the list was too busy to accommodate me. I would be discharged today and wait for test results, and then results as an outpatient. Why was I not booked in a few days after my arrival here, as it was obvious I needed these tests? So after 3 weeks of observation at the hospital, I have no diagnosis or prognosis, and my untreated condition has worsened. I also have observations on end-of-life care, and am now a signed-up member of assisted dying, but I will keep that for another day. But please let me know if you want me to further share in these experiences of my recent admission. And of course, there was also someone denied that care that comes from my hospital bed.
That's a conclusion. Yeah, we've got the lady's contact details, and we'll obviously respond to her formally.
Jessie will get that.
Yeah, so Jessie, so I mean, the real issue for me is the coordination between different parts of the hospital and how that is undertaken. And I mean, as you know, having worked more from a social care perspective in relation to discharge in the past, you know, the view has always been, you know, on day one when somebody enters all the different processes that they've got to go through. So let's get that agreed on day one that they enter the hospital, and let's get everything timetabled so that we can get them out as efficiently and quickly as possible. And that's what we really need to do, is work in that way. So I think we need to give this lady a big thank you for pointing out those issues. Actually, really helpful and beautifully written and nicely written, and kind in the way she's done it. But we do need to give her an apology without a doubt for her experience. Okay. All right. Is there anybody else? There's a lady there.
I've been pointing that out for years, that departments don't talk to each other. I had the Camry yesterday down my throat. I've got my scan on Monday, but I won't get to see anyone until December for the results. Crazy. I don't believe all data numbers. A friend of mine has got a 6-year-old son, broke his arm in 2 places, waited 4 hours in the reception. I thought you had a kiddies area in the A&E department. Wasn't taken through. Yet on a Friday night, he was sat in the reception area after being triaged in the reception area on a Friday night with a broken arm. Crazy.
Does anybody want to respond?
Claire? Because we don't know the details of the individual.
Hi, thank you. Happy to have some further detail. Obviously, I know it's about someone else's care. There is a paediatric area in ED, so obviously it's really difficult for me to describe. And of course, while we can say that we're seeing more people within 4 hours, there are also people that we don't see in 4 hours. So obviously we're aware that people do wait for a long time, and we want to obviously work to get those down, as quickly as possible. So happy to reach out to your friend and obviously see what we can do to learn from their experience of care. And obviously you talk about you've had a diagnostic procedure, so obviously I'm happy to look at to see what we can do. Obviously we booked you in for a follow-up appointment in December, but obviously I wouldn't expect you to wait for your results from what you've recently had done until that time. So happy to discuss and see what we can do to help you.
Okay, thanks Claire. Anybody else? I can't see anyone else.
Sorry. You say that. You're only doing that because I'm here moaning. I can't be the only one. There's people that don't come to these meetings and don't speak up that are having to wait.
Yeah, so
because I've said it here now, you're going to sort something out. There's people out there that are in the same situation as me that won't get sorted out.
So one of the things we discussed earlier on the agenda was having a deep dive into the whole issue of waiting lists and how we would actually, the prioritisation issues around waiting lists. So we'll have that to our next meeting. I think your point is well made. It's the same point as the previous lady has just read out in terms of planning across somebody's whole pathway and their whole health journey rather than one individual part of it. And I think the point is very well made. And
And if we can look at that when we look at that issue of waiting lists as well, that would be really helpful. Okay. Anything else from anybody else? No. So on that basis, I would like to thank everybody for coming today. I'd like to thank all colleagues for their participation today. And I think we should particularly just finish by saying thank you very much to Chris for all you've given over the past year and a half, and we look forward to you getting better, giving us detailed accounts of your experience in whichever hospital it is, whether they be good or bad, and looking forward to your advice when you get back on Ireland. So thank you very much, Chris, and all the very best to you, Patrick, in the future. Thank you.